challenges like all of them just like that. Like we still have more problems to solve with AI and data. And so as ambassadors, we decided that this year's theme for WIDS will still be around healthcare, and to be precise, women's healthcare. Right. So in this session, like it's going to be wonderful. We are going to see how, AI and data can help us transform women's health. So welcome, and yeah. So this is our goal, that just like the video that I shared hasn't really changed. So Women in Data Science Kenya is a regional event, independent event, but part of global WIDS initiative that was started in Stanford University. So our aim, just like the global initiative, is usually to inspire, especially newcomers, to join the field of data science, and not just to inspire them to stay, to just hang in there, but to support them, right, to stay in the field, and supporting them through WIDS events that we usually host every year. That's the Datathon events and the conference events, just to bring in, phenomenal women doing fantastic work in data science and machine learning to inspire us. And we've seen progress around that. So we also believe that a good community, like good data science community, is one that embraces diversity. So diversity is also key for us. So we are also into educating everybody regardless of gender. So yeah, welcome to WIDS community. If you're joining us for the first time, but I'm seeing familiar faces. So I'm so glad that we have worked all this, and you guys still want to learn more and more about how we can use AI and data science to solve real life problems here in Kenya. And this is quite exciting. So yeah, this is the team that was behind this. I think we have Kigo. We did some wonderful jobs. So if you can just stand and wave, Kigo, we have, he's here, Samuel Kigo. He's a senior data scientist. We have Brian. Brian is the lead data scientist at Diamond Trust Bank. Thank you very much, Brian. We have Jen. Jen, if you can just stand and wave. So Jen is a data scientist. She's currently a student, actually. And then I wonder if we've left somebody out. Otherwise, yeah, this is the whole team. We will be switching between screens, between these screens. So if this one is not working, we look at the other one. But yeah, so that's the whole team. We couldn't host or do everything we do in WIDS Kenya without the support of these wonderful organizations. Microsoft has always been our big support. Microsoft, and within Microsoft Africa Development Center here, we have Microsoft Research and the Garage, two teams that have always been helping us. We do host some of our events in Jubilee, the iHub, JHub, and UON as well, and Moringa School. So Kenya Airways, they have really been part of us, supporting us in this journey, and that's quite exciting. Well, this is the best part now, right? So officially, you know, Kathy, I would like to invite Kathy, who is our managing director here at Microsoft Africa Development Center. So Kathy Muraga brings over 15 years of experience in IT, spanning sectors like manufacturing, aviation, banking, and technology. She currently leads Microsoft Africa Development Center as the managing director. Previously, she served as the head of engineering at Stanbic Bank Kenya, where she led digital transformation and reported to executive leadership. She has also, held executive leadership roles in IT operations, in cybersecurity. She holds a computer science degree from African Nazarene University and has completed executive programs at Oxford University's Saint Business School and Columbia Business School. This is just like among others. So Kathy is also so passionate about advocating for women in technology. She's a co-founder of Hanover and actively, champions inclusive innovation and STEM outreach across Kenya. She's fantastic woman in tech and my mentor. Hey guys, let's welcome Kathy. Yeah, thank you very much, Kathy. We are so honored that you could join us and kick us off. Thank you.
Thank you so much. And before you sit, I just want to celebrate you, Millicent, for doing this, putting this together. And please, can we give her flowers? Receive your flowers. Well done. Well done. Well done. Yeah. Wow. As you read my brief, I was like, who is that? All right. Good afternoon, everyone. It's so pleasing to see the room here and also everyone else who has joined online. And before I go to my remarks, I was just reflecting before I joined Microsoft, and I'll be 3 years in June, at Stanbic Bank, where I was head engineering, and prior to that, the chief information officer. I was privileged to I think I was the first leader for data and analytics team. So I was looking at the slide that Millicent was taking us through, Jubilee Insurance, Kenya Airways. I think I also saw DTB. I have fond memories of working with data analysts and data scientists. This team rocks and it's a great time to be a data scientist because right now, without data and telling stories without data, business leaders are blind. Yeah, thank you. So let me go to my notes. It's really pleasing, as I said earlier, to see such a diverse and engaged audience here today. It's particularly pleasing to see gentlemen in the room. As much as this is WiDS, it's always a pleasure to have a diverse representation. And it's an honor to open this session. As we embark on this journey together, I just want to emphasize the importance of inclusive innovation in AI and data science. I say together because I'm a fellow lady in tech, and I'm a fellow practitioner in the tech industry in Kenya and certainly in Africa. The theme this year is Precision Health for Women, the role of AI and data science. And it's really looking forward to seeing how technologies are reshaping the future of women's healthcare. As I was preparing for this, once in a while, does anyone go to TikTok and spend hours? You go in thinking, I'm just here for 10 minutes, and then you're like, okay, can I do other things? As I was preparing for this, I took note of content creators who would come to my feed, aligning with health matters. And right there, I started thinking about what can we borrow as data scientists or those practicing from a technology perspective, looking to leverage AI. They are great content creators or who tell such great stories on TikTok to inform, or agriculture, like this is the right pesticide for your land, or or even financial services. You need to save, an example. So I thought about how about healthcare, and how do we ensure that whatever is shared is actually precise or is the right thing? Because a lot of people, yes, evangelize, but is it credible? Yeah. So from enabling early and more accurate diagnosis of conditions like breast cancer and neurodegenerative diseases to advancing personalized and preventative care tailored to women's unique health needs, AI and data science, it holds immense potential to drive impactful change. And again, as I was preparing for this and just going through, I won't say how many minutes on TikTok. I just wondered, and to my first challenge, how can we leverage AI also to change some cultural or sociocultural stigma, especially associated with detecting some of the conditions that we know? For example, a few years ago, I saw an article in the Nation newspaper where this young lady was advocating more of a different way of testing cervical cancer. Because for the ladies in the room, being tested for it's so intrusive. There's this whole, I mean, you feel like somebody's in your business, if you know what I mean. And it's so pleasing to see now their kits you can test yourself. And therein, the thing I like about this example is the value of inclusion. So even as you're attending this today, my first challenge is how how are you thinking about those real life challenges? And because perhaps either you're a gent or a lady, what are those things that really need to receive the right limelight, either to influence policy or funding? And because of our respective gender or we've walked a particular path, how can we influence solutions and then now leverage things like AI? The second item I'll touch on is Microsoft's commitment to empowering women in STEM. That's why I'm equally proud that Millicent continues to run with this. Microsoft continues to be deeply committed to empowering women in STEM and tech leadership. Don't worry, it can happen. And we believe that diverse perspectives are crucial for driving innovation and solving complex challenges. And this has been the perspective, because Microsoft turned 50 years ago, 21 days ago. And if you look at the Microsoft 2024 Global and Diversity Report, women constitute 31% of core workforce globally. And in technical roles, women make up 27%. Not too shabby. You know why? For those who took STEM related degrees, I don't know about you, but in my class of 40, we were 9. And out of 9, only 5 graduated. And out of the 5, I only know 3 of us who rose to leadership positions. Fourteen in Kenya, 2 in Uganda. In these universities, and it's both public and private, you find the same phenomena. A class of 100, either 10 or less than 20 are ladies. And then the numbers thin as you go into 3rd or 4th year. And when we dig deeper to find out why is the drop-off rate high, give me a wild guess. Anyone wants to hazard a guess? They say it gets harder, and it is true. And I can only imagine for those who want to pursue data science courses, because if I remember my days of computer science, we did a lot of calculus, statistics, and it is important. So at Microsoft ADC, we are very deliberate with these universities that we've partnered with. We started off ADC Wins, Women Inspiring and Nurturing Students, and our focus is 3rd-year students. It's a mentorship program, runs for 1 year, and we match students with ladies working in Microsoft. We managed to mentor 70 ladies last year, and it's an experiment. Given that it's a tech company, apologies, guys, we'll just have to keep doing this. Given that it is a tech company, we leverage ladies not only here in Kenya, but also in other countries. I said it's an experiment because we want to see, will these ladies who are mentored, will they stay on with the course till the end? We did 70, and this year our target is 100. Even right here at ADC, we're also Microsoft has demonstrated by numbers that you're still committed to ensuring females are represented. And right here we have out of a staff complement of close to 600, 27% are women. And we hold different positions, including leadership, myself, and also the lady who leads the Microsoft Research Africa, Dr. Jackie O'Neill. Because it's one thing to show numbers, but it's another to show actual people. I think somebody needs to go on mute. They've gone quiet. Yeah. So, but even also externally, supporting initiatives such as this one today, we aim to inspire more women to join the field of data science, and also just to continue conversations also when we do engage with government agencies. And just to showcase that if Kenya is truly to be the Silicon Savannah, don't we need more numbers joining institutions of higher education, for example? Kenya government launched the AI national policy. And as you know, AI is fueled by quality data. So we do need data scientists. Another item that's very exciting to me, I was quite heartbroken when I saw, similar to you in the news, that mathematics will stop being a compulsory subject. Now I'm optimistic because I know, I think it is the headline, is it yesterday or this week, that is now being considered to be put back because mathematics is key. Just think about your roles as data scientists and the absence of mathematics. So for us to really drive the agenda, even coming back to today's theme, my last area, as I was preparing, what's AI impact on women's health in Africa? So I asked Copilot, what are the most pressing issues in women's health? Gave me many. And I was having a chat also with Millicent. The first item it says is maternal mortality. It talks about 530 deaths per 100,000 live births. The second item it highlighted is gender-based violence, which is about 45%, impacts 45% of women aged 15 to 49. The third item, cancer, with only 13.9% of women having undergone breast cancer screening. And Copilot continues to give proposals on how this can be addressed. But then I asked myself, an AI model will only tell you, Copilot only told me this because that data exists. How about the many challenges that affect women's health in Kenya that are not in a report somewhere that Copilot can read? And what can this community do to try, how can we influence policy or how can we drive awareness so that these things come to the fore? And also fully aware that the title woman is so broad. So when do we become women? And then if you look at it from what's the population of Kenya, and then you dissect the different women challenges at per age, each age group. So I was like, it's an exciting time to be and also leverage AI. But how can we surface out what are all these things that really affect women, or maybe the major ones, and how can we truly leverage the AI tools? Because it's truly a tool. As we move forward with today's program, I encourage each of you to engage, collaborate, and be inspired. Why I put this and I mention this is because I've been a member or a beneficiary of such communities. It is courtesy of such communities I found mentors. And a mentor is not always somebody who I'll tap on their shoulder and say, can you mentor me? Like the relationship I have with Millicent. A mentor to me, courtesy of such forums, has also been sitting in a forum and consuming the information somebody has prepared. These forums have also been a door opener for me, similar forums. That's why I really encourage the participation. You never know, perhaps your next employer is here, you never know, or your next colleague. And that's really the power, especially if you look at women in STEM, and especially those who are deeply introverted. I've had numerous stories of people's either careers have changed, courtesy of such forums. So really take advantage of them for this forum and also today's conversations. As I wrap up, I look forward to, and this is my challenge to you, Millicent, and also the wider WiDS team. I look forward to seeing what knowledge and insights come out of this, and also how can we really influence policy and also start to shape narratives at a national level. Because it's great we have these conversations in such beautiful premises, but the real impact is when we start shifting conversations beyond these beautifully curated spaces for true impact to happen. Thank you very much.
Wow. Oh my gosh, I think now it's my time for the hug. I think you wanted the hug. Yes, yes. Thank you very much. Thank you very much, Kathy, for a powerful start to our afternoon, guys. Let's do it again. Another round of applause, please. Yeah, that was quite, insightful, and you've left us with, some questions, guys, for us to answer. We have a lineup of AI researchers who will be, and also healthcare professionals, right? Dr. Wambui is right there. So at the end of the day, like impact, right? How is this session going to be impactful, like beyond just this sitting? Like, yeah, I think we'll get back to you, Kathy, with an answer. But we are so honored that you could create the time to come and be with us this afternoon. It meant like the whole world to us. Thank you very much, Kathy, again. One more time, guys, as I bring in the next speaker. Okay. So I wonder if Lillian is already on the call. So this is how the rest of this session is structured. So we will have, after the opening remarks, we will have um, our technical talk just before the keynote, because she has to go. So we will do the technical talk, then we will do the keynote. After that, we'll do a quick hands-on experience. Remember when we I mean, earlier this year, we worked on a datathon challenge. And in that challenge, we were addressing a problem on, women's brain health, right? So we have a solution to the problem that you are solving. So we will see how that went, and then we'll have a spotlight talk by Terry, and then we will have the panel discussion, which will be quite an interesting one. So I wonder if Lillian is on the call right now, or if we should just go straight to. She is. Oh my gosh. Lillian, please go ahead and share your screen. So, but wait a minute. So Lillian is going to do, okay, I was supposed to introduce you first. Lillian, do you mind if I introduce you first? Just 1 second for
No
introducing
problem.
you. Okay,
Okay, no
okay, right.
problem.
Thank you very much for joining us virtually, Lillian. We are so excited that you could make it. Yeah, thank you. So, where is it? So right before our keynote, because Lillian has to go, we will have this talk on, you know, early detection of these diseases like breast cancer, brain health, and the role of data-driven diagnostics. And Lillian is going to lead that. So who is Lillian? Lillian holds a bachelor's degree in computer science from Strathmore, and master's in analytics from Georgia Institute of Technology. She brings a unique blend um, of technical depth and strategic insight, with a passion for empowering organizations to unlock the full value of their data. So she's a strong advocate for building data-driven cultures, and helps teams turn insights into impact, right, guys? Always with clarity, confidence, and fairness. So Let's welcome Lillian one more time and give her time to share back her screen. Thank you very much for joining, Lillian. Over to you. Cool. And we can see your screen, only that you are muted, I think. Okay, you are now okay.
I am okay now, right?
Yes. Yes.
Oh, okay. Thank you very much. I am very happy to be joining, albeit virtually. I'm still very excited. I'm sure there are some familiar
Lillian,
faces.
just one second to just double check if Faith has a question. Faith, you have your hand raised. I wonder if you have any question or it's just by mistake. Okay, it was just something else. All right, go ahead.
All right. So I'm very excited to be here. I've loved the opening address by Catherine. So I'm just going to jump right onto my presentation. I'm really sorry that I couldn't be with you guys at Microsoft today, but I think we can still share ideas and learn something from each other, even if we are not together physically, and that's the beauty with technology, so we are very grateful for that. So I'm going to start on my presentation, if everyone is okay with that. If you have any questions, you can drop them on the chat, and then once I finish the presentations, then I'll take them on, or anyone else also from the WiDS team can also take it on. So my presentation is just going to be around precision health for women and the role of AI and data science in the same. And we are going to look at some of the insights that we have gotten from the WiDS Datathon in 2024, because that was also around women's health, because it was something to do with timely diagnosis of metastatic cancer, breast cancer in women. And this year it was ADHD detection, but specifically for women, because it's a bit harder to detect ADHD and diagnose it early for women as compared to for men. And that's because of several reasons. So that's what we are going to do today. So the first thing I'll do is just do a bit of an introduction. And I was just looking through the internet just to try and understand for the research around clinical studies, is it the same? Are women always represented? And I found that historically, women have been significantly underrepresented in clinical studies. And therefore, this has led to substantial gaps in health knowledge and also services that are tailored specifically to women. So you'll find that in the clinical studies, they'd probably have more men and lesser women, or even not have women completely. But when you're diagnosed with a disease, then you're still given the same services or the same medicine as compared to a man, and yet maybe a woman wouldn't really respond to the treatment the same way a man would, and that's because we are built quite differently. So that's something that we need to keep in mind even as we are going through this presentation. And therefore, this information deficit impacts conditions uniquely or primarily affecting women. So there are some conditions that are specifically for women, and this can be in the case of breast cancer, because in as much as men can get breast cancer, it's very rare. And if you remember from the data from in 2024, we had a gender variable and we didn't have any males. So ideally, this is a condition that affects primarily women, and also conditions that present differently between genders. And some of these conditions would be heart disease, depression, and even ADHD. When you think about postpartum depression, that is specifically for women. And then for ADHD, does it present the same way between a man and a woman? And then now when we look at the two previous WiDS datathons, there have been initiatives to highlight practical applications of AI and data science addressing these critical gaps, right? And they're focused on women-specific health challenges. So we had breast cancer in 2024, and in 2025, we have ADHD. So ideally, WiDS is also helping to push the agenda that maybe we can use AI and data science to actually see how do we transform precision health in women, and even just health generally speaking. So we'll first look at the case study that was done in 2024, and that was the timely diagnosis of metastatic breast cancer. So for anyone who participated, I don't know if you remember the overview and what was the challenge for the datathon, but if you did not participate, then I'm just going to give you an overview, what the challenge was, the importance of the same, and also the goals that we needed to actually achieve. So ideally, we got some data from Gilead Sciences, and it gave us a real-world data set from Health Verity. And then the data set included patient demographics, so details about the patient. It can be their age, BMI, then diagnosis, treatment options. What are the options that you have once you're diagnosed? If you're diagnosed with cancer, what are the treatment options you have? And if you're not, then ideally you might not have any treatment options, or you can be told on what to do so that you avoid having a diagnosis later. And then we also had insurance details. So how are you paying and what kind of insurance do you have? Then we also had socioeconomic data. So just details about your social and economic capabilities. How much are you earning? Maybe the number of people in your family. Where do you live? And lastly, we had environmental toxicology information. And this just was information about the environment that you live in, where you live in. So what's the amount of nitrogen in the air, and other environmental toxicology information. And this was from NASA and Columbia University. So the challenge here was to predict if patients received a metastatic cancer diagnosis within 90 days of screening. So ideally, it has two parts. Did you receive a metastatic cancer diagnosis? So that's number one. So ideally, it can be a 1 or a 0. So 1 meaning that you actually got a cancer diagnosis, and 0 you did not. And then was it done within 90 days? So we are looking at the timelines. Is it being done in a timely manner or not? And do we have factors that affect how fast you get your diagnosis? And we know that getting a timely diagnosis also can help improve your chances of survival, and even in terms of early intervention in the disease, and therefore you might not really it might not proceed to becoming something worse. So the importance of this in timely diagnosis of metastatic is crucial due to its aggressiveness with delayed treatment, and this can potentially exacerbate disparities in healthcare access and also outcomes. So ideally, you would want to have timely diagnosis so that you don't have the cancer becoming more aggressive and taking over someone's body. Therefore, the goals were, the primary one is to identify relationships between patient demographics and the likelihood of timely treatment. And that's why we have all the variables that we've been provided with. So are there any relationships in terms of how timely your diagnosis is versus the variables that you carry? And the secondary one is to investigate the impact of an environmental hazard on diagnosis and treatment. And that's why we've been given environmental toxicology, because ideally, I think it's not very common to think that maybe environmental factors can affect how timely your diagnosis is. And I think that's why we wanted that data in order to see whether there's any relationship there. So that's the overview of the case study that was done in 2024. So for 2024, because the data was already complete, we had a winning solution. And when I checked, it was actually a winning solution between a team of 2 people. So it was a man and a lady. And it also just shows the collaboration. So as a lot of people have mentioned, diversity is very important. So therefore, it was a team of a lady and a man. And another thing that I found interesting was that they actually didn't know each other, the winning team. So the man, I think, is from Nigeria. He works with Omdena, and the lady is in Ireland. And they found each other on Kaggle. They decided to team up, and they worked together on the project, and they developed the winning solution. So I just thought that maybe it's important to mention that. And I found it quite interesting because technology allows us to collaborate and work with people who we don't even know from different parts of the world. So the winning solution was a model architecture that included both base models and a meta model. And therefore, you might ask yourself, what's a base model and what's a meta model? So when we talk about base models are just individual machine learning algorithms that are trained separately on the same task. So you can pick whatever machine learning algorithm that you think might fit the task at hand, and then you train them separately on this particular task. So for our task here, it was a classification case whereby we are saying you either have cancer or do not have cancer, and you get timely diagnosis or you did not. And then each base model then captures different aspects of the data patterns, of the patterns in your particular data set. And then you're able to predict once it has those patterns. If you present it with new data, then it's able to identify patterns that are similar to what it has seen during training, and therefore it's able to predict. So the base models that they used was CatBoost. So they used 2 CatBoost models and 1 XGBoost model. And they mentioned that they selected these particular models because of their strength in handling categorical data and also missing values. And if you looked at that data set, I think we had quite a number of variables that had missing values. And therefore, because you don't really need to treat this missing values, and you also don't need to do a lot with the categorical data, I think they can also be very robust because you don't have to do a lot of work on them if you use CatBoost or XGBoost. Then we have a meta model. So as I mentioned, they use 2 base models and they had a meta model. So you ask yourself, what's a meta model? And a meta model can also be known as a blender or a stacking model. And just as the name suggests, it's trained on outputs or predictions of the base models. So you are using the outputs of your base models, and it learns how to best combine the predictions from the base models to produce a final output. And therefore, you see, this is not just taking one machine learning algorithm and just plugging it into your task and expecting it to produce very good results. It can happen, I'm not saying that it cannot, but when you think outside the box, then you're able to get very good solution. And I think that's what these guys did here. And probably that's why they got such a good solution. And the solution that they used for the meta model is actually a logistic regression. So you see, they used quite sophisticated base models, which is CatBoost and XGBoost. But when it came to their meta model, they just used the logistic regression and clearly provided a very good output because they had the best score, and therefore their solution was the winning one. So when we look at their solution, it's an ensemble because you're just not using one particular model. So they combine different things in order to get a very good a final model to use. And therefore, this is an ensemble because an ensemble is just a combination of different models. And ensemble learning strategy allowed for improved robustness, better generalization, so it better understands data, and it doesn't understand it to the point where it's just generalizing to that data. But when you present it with new data, then it's able to generalize well and it's able to predict better. And therefore, it also ensures interpretability. When you look at logistic regression is not a very complex type of machine learning algorithm that you're not able to understand its output. And that's one of the key things that we need to always think about in data science when we are handling tasks. What kind of algorithm can I use that will allow me to also give interpretability? So when I'm asked, how did you arrive at this output? Then I'm able to give good reasons and also interpretable even to someone who does not have data science skills. So aligning with the challenges emphasis on equity and explainability. So I believe that's why they had a winning solution, and I just thought it's important we go through the winning solution. For 2025, I do not think we have a winning solution yet. unless that has been released. But when I was doing my research, it wasn't there yet. So in conclusion, when we look at the WiDS data for 2024, one of the interesting insights that the winning team noted was that they found that environmental pollutant features such as nitrogen dioxide, ozone, and PM2.5, I'm not very sure what that stands for, they emerged as significant variables in predicting whether a patient would receive a metastatic cancer diagnosis within 90 days of screening. So you see, this is something that you probably would not think if you're asked off the top of your head. But at the same time, when you look at data, then data does not lie. And it can also point out some of the things that maybe we did not even expect. And this is an unexpected finding because it means that environmental factors can actually influence how timely your diagnosis is. And therefore, this highlighted the potential influence of environmental exposure on cancer diagnosis timeliness and also contributed to broader discussions on environmental justice in healthcare. Because you might find that some of these environmental pollutant features are in certain areas where people live as compared to other areas, and it might be maybe low income areas as compared to where people with middle income live or high income. And therefore you start thinking about environmental justice and also healthcare. So what can we do to ensure that everyone is receiving equitable healthcare, and even the places they live in dignified places, and therefore there's no pollution that can affect their health. Therefore, the conclusion of this case study, it just exemplifies how combining diverse data sources with advanced AI techniques can not only improve accuracy of cancer diagnosis, but also illuminate social and environmental factors that influence health outcomes. It demonstrates the promise of precision health to address health inequities and ensure that timely life-saving treatments reach those who need it the most. And therefore, we can collaborate with healthcare professionals, with governments in terms of the policies that are being made to ensure that we are making decisions that are equitable and they are fair to every single person who lives in a country. And therefore, not one person is treated unfairly as compared to another person being treated fairly. And you see, data science helps in terms of that. Because if you don't have data, then you're not able to prove anything. But with data, you're actually talking facts, but you're not just discussing things because of your gut or maybe things you just think. Therefore, they help in terms of that. And I think it's a good place where data science can intersect with healthcare. When we look now at the second case study, which was the datathon that is still running, I believe it's almost closing. The overview of this, it's detection of ADHD in females. And I think it's specifically for females because when you look at the data that currently exists, you'll see that ADHD affects 11% of adolescents, with 14% being boys and 8% of girls being diagnosed. So there's a bit of a spread there of around 6%. And you will ask yourself, is it that girls don't have ADHD more than boys, or is it that girls are not diagnosed early? And when you still look at data again, you'll find that girls often go undiagnosed because symptoms that show ADHD, they present very visibly. So you'll find that it's someone not being very attentive, so it's hyperactivity, it's it's just visible symptoms, and girls might not have it, maybe due to cultural norms or even biological factors. And therefore, girls can go undiagnosed. It's not that they do not have ADHD, it's just that it's mistaken for other things. And if ADHD is not diagnosed early, and therefore interventions made early, they can negatively impact the person's life, not only mentally, but even just your daily functioning. You can go through your life, you're dealing with a disease that you don't even know you have, and you're struggling with it, and it's been left untreated because it was not diagnosed early. And of course, early diagnosis means that you can even get better care, and you might even learn how to deal with it better even as you go through life. Therefore, if girls were diagnosed the same way as boys, then it means they can even go through their life and live better lives because of that. So the data that we were working on was developed by an Boas Women's Brain Initiative in collaboration with Cornell University and UC Santa Barbara. So it provided us with reproducible brain charts that had brain imaging and rich demographic and emotional health information. So we had a huge data set that was information on brain imaging. So you'll see that there are probably a lot of differences between how a lady's brain functions and how a male's brain functions. Then we also had demographic data about the individuals, so these kids, because it's actually kids data, and also emotional health information. And there's also socioeconomic information about their parents in terms of what kind of education do the parents have, what kind of jobs do the parents have, are they a stay-at-home parent? So you also have that information that just augments on the information on the brain. So the challenge here was to build a multi-output model to predict both an individual's sex and ADHD diagnosis. So multi-output here just means that you have two outputs. So one, you're predicting whether the individual is a female or a male. And then two, you're predicting whether they have ADHD or they do not have ADHD. And therefore, the other thing was to utilize functional brain imaging and socio-demographic, emotional, and parenting data to also predict these two outputs that we were expected to come with. And the importance of this is you get to understand sex differences in brain activity associated with ADHD, and this can enhance early diagnosis, particularly in females. And the reason why we say it's particularly in females, it's because females might not really have those externalizing factors that you would see in boys. But then maybe when we look at their brains and how they're functioning, we'd be able to pick out some of the things that are running through their brain that would be able to detect this lady looks like they have ADHD. For males, the brain imaging data can help us to still do the diagnosis, but the externalizing factors are already doing a good job in terms of that diagnosis. So with brain imaging for girls, then it's going to be of help to do early diagnosis, and therefore you have early interventions of the same. Then the insights can also guide the development of personalized treatments and targeted brain therapies for both genders, because maybe what works for females might not work for males, and therefore you're able to create targeted treatments for males and targeted treatments for females. And then also tools developed from such models may help clinicians detect ADHD early in girls, reducing long-term cognitive and emotional burdens. And I think I've spoken about this. So you're able to go through life knowing how to deal with it, how to know when maybe it's flaring up, like maybe you have ADHD and it's flaring up, you know how to deal with it, as compared to being in your 30s and now you're being told that you have ADHD and you're even wondering, am I normal? Am I going to still do my job the way I'm meant to do? So that's the importance of such case studies. Since we don't have a winning solution, I just went through some of the insights that we got from the initial data analysis. So we did an initial data analysis, and I did not analyze the brain imaging data at that point. So I just analyzed the social demographic data. And the first thing that jumped out is that males had a higher ADHD diagnosis than females. And therefore, you ask yourself, maybe what could be the factors that are making males look like they have a higher ADHD diagnosis. And I went through the data just to try and figure out why is this the case. And you'll see that there are some biological factors that can be an influence in this, because males tend to have higher impulsivity and hyperactivity, and therefore they make ADHD symptoms more visible. So if you looked at the data, there was something about impulsivity and hyperactivity, and if those two variables are quite high, then it means that the probability of this person being diagnosed with ADHD is pretty high. So males have this, and it's very easy to see it because it's quite visible. You'll see someone is very impulsive. Even as a child, you can tell a child who's very impulsive, a child who's very hyperactive. And once maybe you do a bit more analysis, it's a bit easier to diagnose. But you see, on the other hand, if you have a lady who is not impulsive, they are not hyperactive, even if they are encountering some challenges, ADHD might not even be the first thing that comes to the mind of a clinician when they are diagnosing what might be the issue with the child. Then there's also hormonal influence, and we know that males tend to have testosterone, and it may contribute to riskier behavior and attention issues, and therefore it increases the externalizing symptoms. Females don't have a lot of testosterone. I stand corrected on that. I don't know, but for males, this is the hormone they have, and therefore it can contribute to riskier behavior, and riskier behavior can just be said as being impulsive or taking more risks. Then there are also behavioral and symptom differences between males and females, and you'll see that males show more external symptoms, as I've mentioned, so hyperactivity, impulsiveness, and females display internalizing symptoms. So these are symptoms that are not very out there, so they are not external. And most of this would be misdiagnosed as anxiety. So you have someone who's not very attentive, but it presents itself as anxiety. And therefore, females can go undiagnosed or misdiagnosed, where they're told maybe you have anxiety disorder as compared to ADHD. And lastly, there are also cultural and societal norms that can cause these differences. And you'll see that with teachers and parents, they notice ADHD more in boys, and it's because maybe of their hyperactivity. When you're in class, you find that maybe a child is playing too much, they are unable to sit still through a lesson, they're very impulsive. So parents and teachers can identify this. And another thing that I read while I was just doing this research was some cultures tend to tell girls that that's not how a girl should act. So even if you have a very hyperactive female child, you're told that's not how girls are meant to act. You're not meant to be jumping around on tables. You're not meant to be very hyperactive. You're too risky for a girl. So there are those things, and even when now you go to a clinician, it's almost a girl can't do that. And those are just some of the societal and cultural norms that can contribute to these undiagnoses or misdiagnoses. And that speaks to still gender bias. So you'll find that girls are mistaken to have mood disorders because you're dealing with quite a bit of hormones. So you have a cocktail of hormones, and they'll just say, oh, it's hormonal imbalance, mood disorders, anxiety, and therefore ADHD might not even be among the things that is on the radar of the clinician. But with now brain imaging data, this can help to actually diagnose the right thing and not use gut feelings or cultural norms or societal norms to diagnose someone, but rather you're using facts and data to diagnose this person and give them the right diagnosis and the right kind of care and the right kind of medication in order to deal with the condition that they're actually dealing with. So in conclusion, with the second case study, artificial intelligence and machine learning offer powerful tools for uncovering nuanced patterns in complex data sets. So when you look at brain imaging data, it's not very easy information to consume or to even analyze. But then machine learning and AI gives us an avenue to actually analyze this, and it's able to pick certain patterns in this data set that can help us know whether someone has ADHD or not. So given the significant biological, behavioral, and societal differences between how ADHD manifests in males versus females, traditional diagnostic methods often fall short in identifying the conditions. And I've just spoken about that. So ideally, it's not saying that we don't look at the traditional methods, but rather we augment traditional methods with AI and machine learning and now brain imaging data to see whether we can come to a better way of diagnosing ADHD. Secondly, AI models can analyze brain scans alongside emotional, demographic, and parenting data to uncover subtle ADHD markers, especially internalized symptoms that are pretty common in females. And therefore, this helps detect sex-specific brain activity that is linked to ADHD. So you're able to identify the brain of someone who might have ADHD and the brain of someone who does not, even if they don't have those externalizing factors, and then accurately predicting ADHD even without visible symptoms. So that's what we've spoken about. And then lastly, which is, I think, very important, supporting earlier tailored interventions for females. So these interventions are specifically built for females, and therefore they know how to deal with ADHD in females. So ultimately, machine learning models trained on rich multidimensional data, like those from Healthy Brain Network, the one that we are currently working on, can transform how we detect and treat ADHD in girls, ensuring they receive timely support and care before the condition impacts their long-term well-being. So these two case studies just shows that there's a lot that can be done in the health space using AI and machine learning and data science to actually curate solutions that are specific to different genders. So we are not leaving out the males, but we are just saying that maybe some of the solutions we are offering should be different between males and females, and even how we are diagnosing things. Maybe they should be a bit different. But now we have data, we have machine learning, we have data science, we have AI. How can we use it such that it helps us actually achieve these goals in healthcare? So aside from the work that has been done in the WiDS datathon, I just thought maybe we could look at other AI applications that could be done in the women's health space. And I came across 3, and I think some of them are studies that are currently being done, and others are things that have already been done. So the first one is pregnancy-related risks. And when you look at machine learning and data science, you can analyze clinical, genetic, and lifestyle data of individuals to predict risks such as preeclampsia, gestational diabetes, and preterm birth, and therefore provide early warnings that allow preventive interventions that reduce complications for both mother and child. And this, I believe, I think as Catherine was giving her opening remarks, she actually mentioned it. And this would be very, very instrumental when we even look at our landscape in Kenya and Africa. There are some places that women do not even have access to go for scans or to go for clinics in order to identify if they have any risks during pregnancy. And therefore, if we've collected data from women who have been able to go to clinic, so we have their clinical data, we have their ages, we have their socioeconomic information. If we compare this to a lady who's not able to visit a hospital, are we able to tell if they have any risks during their pregnancy? And if it looks like they have those risks, then we are able to tell them, we think you need to visit a hospital so that these risks can be confirmed. And if they are confirmed, then you have early warnings and you'd prevent more deaths, because preeclampsia, when you read about preeclampsia, it's actually a very risky condition that some women develop during pregnancy, and it can be fatal for both the baby and the mom. But if you're able to detect it early, then the doctors can offer solutions to make sure that the baby is safe and the mother is safe, because you just do monitoring, and it's something that can be prevented. Gestational diabetes, if it's detected early, then you're able to monitor and make sure that the mother has very intense care during pregnancy, and also preterm birth. So you don't have a lady carrying a pregnancy and then they have preterm birth. So that's on pregnancy-related risks. Then there's menstrual and reproductive health management. And as you can see, this is specifically for women. So there are AI-powered apps and wearables that help track and forecast cycles, ovulation, and hormonal changes with high accuracy. When you look at your Apple Watch, there are certain rings you can wear, and they do a pretty good job in terms of tracking your cycles. They'll tell you almost to precision when you're ovulating. So if it's a family that's trying to have a child, then they're able to plan around that. Or if it's a lady who wants to, say, travel, and they want to know whether they'd be on their period during their travel, then you see these apps are able to do that for you, and you're able to predict almost to precision when your body is going through certain things. Or if you're feeling a bit lethargic, you're not feeling too well, there are certain hormonal changes that are happening in your body, and you'll be able to tell from this wearable app that people are having. So we can already see the impact of AI on the kind of lives that we are living and how it has even improved the lives of people. So tailored insights assist in fertility planning, contraceptive use, and symptom monitoring for conditions like endometriosis. Lastly, we have mental health care. So machine learning models can detect early signs of postpartum depression. We know that postpartum depression is something that affects women who've gotten children, and therefore this is not something that is for both genders. It's for women. And therefore, if you're able to detect it very early, then you can have early intervention, because postpartum depression can be pretty severe and it can affect the mother. And if the mother is affected, then the baby is also affected and everyone around her is also affected. So in terms of that, it's going to help you be able to detect postpartum depression, anxiety, mood disorders, and you can use patterns such as sleep data, which can still be collected from your wearable apps, speech, social interaction, and even hormonal profiles. And it enables timely and targeted mental health support, therefore improving long-term outcomes for mothers and ladies. So this is almost on my last slide. And even as we speak about AI, data science, machine learning, all these things, we still need to think about ethics and ethical applications of AI such that we are not infringing on anyone's rights or dignity. And some of the things that we need to think about is biases in data sets and AI models, because many existing data sets underrepresent women, particularly those from minority and low-income backgrounds. So you find that your data is collected in certain regions, and therefore it misses out on some people. Biased data can lead to inaccurate predictions and unequal care. So we need to make sure that our data sets are diverse. So we collect data about, just a minute. So you see that you need to do quite a bit of research in terms of collecting data, such that you have data that represents everyone. So it's not just data from a small sample of people who can say access healthcare. There are some people who are not able to go to hospitals. So in such a case, you need to go to them. If you have those resources, you need to go to them so that we have a fully representative population. So proactively include diverse demographics and clinical profiles in your training data, so that when you present it with data that it has not seen, it is not biased. Then there has to be fairness audits. So you need to audit your models. Even if you've deployed them and they're on the live environment, you need to do audits, and you also need to do bias detection so that you make sure that your models are not biased and that they are fair. Secondly, there is also transparency and interpretability. I hope we understand about black box models, and black box models are just models that ideally you put inputs and you have an output. Whatever happens in between, you don't know. And this is discouraged because you're not able to interpret what has happened in here for the decision that we have gotten. And therefore, we need to have models that are interpretable, because you might be dealing with clinicians who might not be tech savvy, and they might not understand your mathematics, statistics, modeling, algorithms. So you just need to speak their language and therefore interpret how did you arrive at the results, and how is your model taking in the input. What is the most important features in your model? Which one is the one that gives the biggest probability of a certain prediction, so that they are able to trust you? Because if someone does not really understand how you arrived at a decision, it's very hard to trust. Therefore, you need to implement explainable AI. And even if you have black box models, then you still have certain techniques that you can use to still interpret your results. And some of them is SHARP and LIME. And I believe during the 2024 WiDS Datathon, one of the presenters spoke about explainable AI, and she demonstrated how you can use SHARP in order to understand the outcomes of your models. Then alongside that, you need to offer clear user-friendly insights along your model outputs to aid clinical judgment. We are saying that even if we give you outputs from our AI models as data scientists, then you still have clinical judgment. The doctors still need to go through the outputs of the AI models, and then out of that, they're able to make a judgment. What do we do in such a case? And therefore, you still need to give very user-friendly insights that are still understandable even to clinicians, and they are able to interpret it and make their judgments very easily. Then we also need to think about privacy and ethical use of sensitive health data. And I think this is such a big one, because women's health data, especially reproductive, hormonal, or mental health data, is highly sensitive. I don't think any woman just wants this information about them being out there. So there is something that really needs to be thought about when you're even working on such AI models. And you'll find that even in hospitals, because I believe Aga Khan in Kenya is actually doing one of these studies where they're collecting information on pregnant women so that they're able to help women in underdeveloped provinces be able to detect risks early. So even when they're collecting that data, they have to be so careful in terms of telling you that your data is safe. We have masked your information, so no one can know that this is you, because health data is so sensitive, and misuse or breaches to this data can cause legal, social, and psychological consequences to the organization that had this data and they misused it, or there were breaches to this data, and also to the individual that this data belongs to. Because you'll find that if your data is just out there and there are some maybe medical conditions you have that you never really wanted anyone to know, it can cause such psychological issues to you, and it can even bring more mental issues to not only women but even men. So if you have any information about individuals, it needs to be protected very well. So privacy has to be of high priority, and also ethical use. So are you using that data ethically? Are you using it for the reasons you collected it? If you don't need certain information, do you really need to collect it? If you have finished using a certain piece of information, do you need to keep it in your database? No, you do not. Therefore, you need to be able to dispose that information in a way that keeps the sanity of the individual and even protects your organization. And lastly, we talk about equitable access and representation, and this is very well tied with biases, because we are talking about precision health must be inclusive, and not just for those with access to advanced tech or specialized care. And when you even look at the ethics and governance around AI, because it's a topic that is being spoken about, there are certain standards and policies that are being developed. There's one that is currently being developed. Actually, it has been developed by UNESCO, and you'll see that inclusivity is one of the biggest things they talk about, because you want to have AI not only advancing certain people, but it's inclusive so that the entire population is moving in tandem, so that we don't have people who are underprivileged being more underprivileged. So it's almost like you're compounding on the injustices that have already been there. And now the more you compound on them, then these people become more underprivileged. So there has to be equitable access. And even as we are building our AI models in healthcare or even in other industries, we need to think about that so that we ensure that we are being inclusive and we are not leaving anyone behind. So therefore, we need to design models that work well across socioeconomic, racial, and geographic divides, and partnering with public health programs and local clinics that extend reach and impact to every single person. So in conclusion, we have spoken quite a bit about precision health and how AI and data science can be applied in women's health. We therefore come to the conclusion that artificial intelligence and data science are redefining what's possible in healthcare, and they are moving us from one-size-fits-all approaches to precision medicine tailored to the unique biological, social, and emotional needs of women. Therefore, we are just not tailoring our solutions based on the very small number of people that we did clinical studies on, but rather now we have data about women and we are able to create precision medicine that are tailored specific to women. Then we also see that WiDS datathon are powerful examples of applied innovation. Even if they are not adopted, then they are very good examples of certain innovations that can be taken in the healthcare industry, and I believe in even other industries, in translating complex data sets into real-world health interventions. Then for the 2024 Breast Cancer Datathon, it emphasized early detection using clinical and genomic data, while the 2025 ADHD challenge spotlighted gender disparities in neurodevelopment health and the power of brain imaging for earlier, fairer diagnosis. And lastly, sustained advocacy and collaboration across researchers, clinicians, policymakers, and technologists is essential to ensure that AI works for all women, not just the digitally privileged. And I would pose that as a challenge to everyone. I believe you are in different industries and you're able to collaborate with people from different arenas in our society, and therefore we can use our skills to better our nation and just take advantage of AI in terms of how can we use AI to move forward and in these different industries. So yeah, that is my presentation. So if you have any questions, you can ask or you can drop them on the chat. Thank you very much.
Wow, Lillian, thank you very much for quite an informative and, so much insights to take away. And I like how you are ending your talk, encouraging us just to try and answer the question that Kathy left us with, right? I'm so grateful. This was such an insightful presentation. Guys, let's clap for Lillian. Thank you very much. I wonder if you have time to take questions. We have like 2 minutes for like questions. Otherwise, I wonder if we have questions for Lillian, guys. Yes. Brian, actually, there is a mic behind there. Beside. Yeah, just. Yeah, and if we have questions online as well, feel free to ask.
So I can see there's one question that has just come on the chat.
Yeah.
I can answer that as the logistics at Downhill are being sorted. So Wambui Kimani is asking, what can we do to have access to data locally? So I think we're on the right track when we look at even the launch of the Kenya National AI Strategy. I feel like we are on the right track in terms of AI and even the conversation about AI. So as Catherine mentioned very correctly, you cannot have data science, machine learning, or AI without quality data. So I think we are on the right track in terms of that. In terms of access, I believe there are certain places you can have access to data for free. I think like WHO, you can access data for free. And it's not only for other countries, but even Kenya. I think there's also Open Data org. They also have certain data about Kenya as well. So I think there are several places you can get data that probably speaks to Kenya specifically. I don't think we are at the point of other developed nations yet, but there are certain places you're able to get data for what is happening in Kenya. It might not be as rich because we do not have the resources to probably collect more data, especially from the underserviced places where maybe the tech has not really penetrated as much. But I think with the little data we have, then you're able to sort of make your decisions. So I think it's an initiative that should probably still be spoken about. And I think with the national AI strategy, this is something that will have to be sorted because you are not able to achieve any of those strategic initiatives if you don't have quality data. Therefore, this is something that has to be done. I believe another place you can get very good data is universities. Universities do a lot of data collections. When you're doing your final year research, then you might have to go to the field and collect data. So universities are also a very good avenue of collecting data. So that is what I would say.
Thank you once again, Lillian. Your talk was like so insightful, and like I wonder if you'll be around for panel session so that we can ask you more questions. But it's okay if you won't make it.
Yeah, unfortunately, I won't be able to make it for the panel session. I'm really, really sorry about that.
No worries. But thank you very much again for taking the time. Your talk was super, super helpful. So thank you for inspiring the community one more time. Thank you. Guys, let's clap for Lillian one more time as she goes. Okay,
Thank you.
so
There's,
quickly,
sorry,
okay,
Wilson. Sorry, Millicent. Is there another
yes.
question from someone there
Actually,
who's physically there?
due to
Okay.
time, Lillian, I think we'll just have to, yeah, because it was like 30 minutes. We were to end at 3:30, and it's
Mm-hmm.
like, yeah. So
Yeah. Okay.
I'll just, yeah. Thank you very much. So,
Thank you very much.
uh, Lillian introduced, different challenges that we have solved in our previous datathons, and Faith is going to talk about one of them, which we worked on in our previous datathon, and she's just going to provide a solution. Most of us here worked on the challenge, and this is like a hands-on. So, because Lillian talked about it more broadly, Faith is just going to present the solution of like that particular challenge. So, without talking much about it, Faith, here is your moment. Please share your screen. Can we clap for Faith? But hey, before you share your screen, Faith, so Faith is a visionary data scientist and analyst known for combining strong technical skills with strategic thinking to drive impactful data-driven decisions. So her assertive yet open-minded leadership style fosters collaboration, creativity, and innovation with a uh, compassionate and goal-driven mindset. She builds cohesive teams while ensuring work remains purposeful and engaging. So Faith is deeply committed to uncovering the stories hidden in data and guiding her teams toward solutions that make a difference. Over to you, Faith. She's a data scientist, analyst, and she loves telling stories with data. So let's see. So this is a project we worked on, and Faith is just going to quickly present the solution, and we will share with you this notebook as well, in case you didn't participate in our datathon challenge. Faith.
Okay, good afternoon, everyone, and thank you, Millicent. I'm sorry I was not able to join you guys over there. I have a really bad cold. So I won't really take time. We're just going to look at the objectives, the data, the model, and the insights because Millicent has already covered a lot and we don't have to really spend a lot of time doing the same thing. So the objective of this datathon was to develop a robust machine learning pipeline focusing on ADHD prediction and gender classification using advanced feature engineering, exploratory data analysis, and machine learning techniques. And why is this important? It's particularly because
Faith,
ADHD.
1 second, Faith. Let me just confirm if like people can see. Wambui, can you see Faith's screen? Somebody's saying they can't see. Can
No.
we all see Faith's screen? Like people joining online. Lillian, can you see Faith's screen?
Yes, I can.
Okay, Wambui, maybe you just need to drop off and log in again, right? Okay.
Okay, thank you. So we were discussing the importance. It's particularly challenging in females, and this is due to the reasons that Lillian has already discussed: hormones, pregnancies, and things like that. Moral, the society, and things like that. So when we identify distinct brain activity patterns, so this study can guide personalized therapies and early interventions. So the key outcomes, sorry, were to look at data preprocessing and cleaning, understanding correlations, regression model selection, model fitting and testing, and then we explain the model performance and then multi-outcome prediction. Yeah, so the first step was to load and merge the data and summary of the data set that we had. We had categorical metadata, quantitative metadata, and yeah, we can go straight to the notebook. So this was just the libraries, but we can go straight to this section where we handled missing values. So you first check if you have any missing values before you start working on your data. Just to check, to look at what is present in the data set that we had. And then this was a heat map of data that was missing after we imputed the data. And I had no other missing data. So straight into correlation. And we have to understand correlation in the data that we had, because it helps us measure the strength and direction of relationships between now the numerical data or variables that we had in the data set. And it's really important to understand how these different features interact with each other and with our target variables. And what were we really correlating? We had neuroimaging data from the matrices. We had quantitative metadata, that was age, cognitive test scores, and things like that. We also had target variables, that was ADHD outcome, and the sex, which was female in this study. So by computing correlations, we can uncover patterns like these. Now, do functional connectivity patterns relate to ADHD diagnosis? And then does age correlate with cognitive performance or ADHD outcomes? And are there certain brain connectivity features that now are linked to gender differences? Or are there connectivity features that maybe are predominant in males and not present in females and vice versa? And what should we not correlate? That was participant ID. It was not an important feature in the study, and also categorical features like handedness, parent education level, and things like that. So we computed correlation by filtering out non-numeric features, and then we computed the correlation. So this was just a heat map to show the correlation. This was a summary of our categorical variables, and we've already discussed that. So looking at the data that we had to look at how ADHD diagnosis was distributed by gender, and ADHD diagnosis on this axis, 0 to mean not present, and 1 here was supposed to mean present. And then for the blue, bars, that represented male and female. And you can see that females really showed a smaller, lesser number as compared to the males in the data set. So that really showed that females, or rather diagnosing ADHD in females is a bit more difficult or taxing as compared to males. And the feature variables that I decided to work with was brain connectivity data, psychological assessment scores, parenting measures, clinical measures, and the demographic information. And all this was in the data set. If I'm rushing too much, you'll just go back to the data set and have a look. So on brain connectivity data, it contained a lot of features, and we needed to do dimensionality reduction before visualization of this data. Mainly first because of processing power and things like that, and also to reduce the time that we need to process these cells in order to come up with an outcome. So it's just like you have to look, or rather to pass through this data, have a really quick view other than having to process the entire data set. Yeah, so PCA can be used to do this dimensionality reduction. And then now you can visualize the data, which is now high dimensional. So we can look at the distribution now. The distribution of brain connectivity values from the matrix that I've discussed. So this was what I got as the outcome after visualizing that sample values. And the key insights that we were able to get here is that ADHD, how ADHD correlates with brain connectivity function pattern. So now this bell shape suggests that most brain connections show weak correlations. I think we discussed that more the last time we were there. We were looking at how these brain regions or things like that correlate with one another. And this aligns with this ADHD-related research, where weak or disrupted functional connectivity is often observed, especially in regions responsible for attention and impulse control. So in individuals that have ADHD, they have a weak or disrupted functional connectivity, and that's why they have that condition. So if we compare individuals with ADHD and those that do not have ADHD, we might find that ADHD brains now have a wider spread or more extreme values, which show dysregulated connectivity. And then the subtle variability observation, peak heights and spread. So the curves were not really perfectly identical. One was slightly higher than the other. So suggests that both distributions were centered around zero or the spread variance. And the density at specific values might differ between genders. So it's possible or possible differences in tails in our data. So it shows that if one gender has a slightly longer tail, it could mean that some individuals now in these groups, either male or female, have extreme connectivity values. Now they have either stronger or weaker correlation. And an overlap does not mean that there's no really big difference. And then we moved on to looking at the heat map of these brain connectivity feature samples. And this is what we were able to plot and get. And then looking at now brain connectivity between our 20 random connections of the brain features. This was what we were able to get. And the interpretation of this was that this plot was supposed to show the difference in brain connectivity between now individuals with ADHD and those without. And I randomly selected 20. Hello?
Yes, we can hear you.
Okay. So the key insights here was that there's a variability in connectivity differences. So some connections showed a higher connectivity in ADHD. Those were the positive bars above zero, while others showed a reduced connectivity. And this suggests that ADHD might not uniformly increase or decrease connectivity, but it alters it differently across the brain regions. And then there's also asymmetry in differences. There's possible functional implications. And then we moved on to the next step in this analysis. Let me just share the plots first. So this was a PCA of brain connectivity by now ADHD status and also by sex. So you can look at the distribution between the two plots. And by interpreting this, we can see that the PCA of brain connectivity data is reducing high dimensional data into now two principal components, PC1 and PC2. Each dot represents now a single individual, and the color coding was just to distinguish the group based on ADHD status, and one was for sex. So on looking at brain connectivity by ADHD status, so the spread points now suggested that ADHD and non-ADHD groups largely overlap, meaning that the first two principal components do not really strongly separate ADHD and non-ADHD. individuals. However, some differences in distribution patterns exist, particularly in the outer regions now, where some individuals may show extreme variation. So insights here were that brain connectivity features may not linearly distinguish these two individuals, and then there are more advanced techniques. And there may be subtle ADHD-related connectivity patterns now, which may require further or deeper feature engineering or domain-specific analysis to find that out. And then on sex, we looked at the plot showed that there was also another overlap, which showed that the sex differences in brain connectivity are not really strongly pronounced, and there are still some individuals from one group extending further out to another group, suggesting now that there are possible differences in specific brain connectivity features. And insights here were that also the first two principal components do not really clearly separate sexes, indicating that there's an overall brain connectivity structure that's similar across genders. And then, however, some subtle differences exist, and further analysis also can reveal such distinctions. So overall takeaways here was that there's a significant overlap for both sex and ADHD status, and then there's also potential subgroups. Some deviate further. So they suggest that there's possible subtypes within ADHD or sex-related brain connectivity difference, and then there's also further analysis needed. So this is just psychological assessment caused by ADHD diagnosis. I think Lillian had explained this a little bit more, so we just want us to move direct into also on handedness and vision scores, things like that. Wanted us to go straight to the model and then the insight. However, we can look at how age was distributed across the data set at the time of this study. And we can see that both groups now, ADHD and non-ADHD, peaked at around 10 years of age. So suggesting that most of these scans that were used in this study were conducted around this age. And then there's also a similar distribution for both ADHD and non-ADHD group, which followed a nearly identical pattern, meaning ADHD diagnosis in this data set did not really appear strongly age dependent. And then there are fewer older diagnoses, meaning that there are fewer individuals diagnosed with ADHD in the older range now, 15 and above, which aligns with clinical trends where ADHD is often diagnosed in childhood rather than adolescence. And then on feature engineering, we picked the targets, which were ADHD outcome and sex, and then we defined our pipeline and built it, and also performed PCA. And then on model selection and training, the first thing was to, splitting the data set, and I used a 80-20 split on the data set. And then I built multiple models, then we're going to compare them. So the first model was the logistic regression model. And these were the scores, precision, recall, and the F1 score, and then a random forest classifier also. And I picked the top 10 features in the random forest, and these are what I was able to get. Sorry. And then I built a hist gradient. And now these were the key findings after the entire project. So the first thing was there's a severe class imbalance because we had 178 cases of ADHD and 65 non-ADHD. So the model was highly skewed towards predicting ADHD, and it struggled to correctly classify 0, meaning no ADHD, which likely represented females with ADHD or non-ADHD cases. And then there's poor recall for class 0 females because logistic regression only had a 3% recall for 0, and then random forest 3% recall, and his gradient 49% recall. So it means that the models are mostly ignoring female ADHD cases, or they fail to detect zero, which is non-ADHD, or a female ADHD, and mostly predict one, which might be ADHD in males. So this is just a comparison for all the models. And then there's a high misclassification rate for females. And what does this mean for ADHD diagnosis in female? So female ADHD cases are likely being overlooked because traditional ADHD symptoms like hyperactivity and external behaviors are more associated with males. And Lillian has said that maybe in the society, females are told, no, you're not supposed to behave like this, or things like that. And that may really shape how someone expresses themselves. And this may suppress these symptoms of ADHD in females. I told you last time, my mom raised us, telling us, no, a female should not be heard before they are seen, and things like that. And also, the models were biased towards detecting ADHD in males, but it struggled with more subtle and inattentive ADHD symptoms that are often seen in females. Yeah, and then sharp, which is a feature important. If plotted, though I plotted it down below, you'll get the notebook, then you'll just uncomment it. So it showed which features contribute the most. And then you might also see that the model is focusing on factors that align with male-dominated ADHD symptoms. And then this was model comparison using F1 score. And logistic regression had an F1 score of 0.83, random forest 0.84, and his gradient 0.86. So the best model of choice here in this case, based on the metric and comparing F1 score and OCRO, his gradient boost classifier was the best model because it had the highest weighted F1 score, which was the key metric now in this competition. And it also had a significant figure of the OCRO, meaning it better distinguishes ADHD and non-ADHD cases. So since diagnosing ADHD in females is harder, it's given an extra weight, a high F1 score to ensure a better balance between precision and recall for these cases now of ADHD in females. And then you can also perform hyperparameter tuning, and I've put all that here, why you should do it and when you should do it. So if the model's performance is close, or yeah, like if you compare in my case, random forest and logistic regression are very close. So if I were to perform hyperparameter tuning, it might bring that distinction. And then also the scores of OCROC, if they are a bit low, that suggests room for improvement. And then also if there's a suspected case of underfitting or overfitting. Yeah. So the findings, we'll discuss the findings, then we'll end there. Yeah, so ADHD is often harder to interpret in females due to several factors, symptom presentation difference. So males are more likely to display hyperactive impulsive symptoms, and females are likely to be inattentive or likely to have inattentive symptoms like daydreaming or difficulty focusing, which are a bit less obvious. And this leads to underdiagnosis in females. And then social conditioning and masking. So females are often socially conditioned to be quieter and more organized. So it helps them mask these symptoms better, and they often compensate for difficulties by mimicking their peers or making their struggles less noticeable. And then there's also late diagnosis and misdiagnosis. There's also diagnostic criteria bias. So most ADHD research are often centered around historically based male-dominated studies, which leads to bias in assessment tools. And then standard screenings may also fail to capture ADHD symptoms in females accurately, and then hormonal influence. So the conclusion here is that there's a difficulty in diagnosing ADHD in females from subtle symptom expression, social factors, late recognition, and diagnostic biases. So this is why the study focuses on gender disparities, yeah, like this study. And then there's also critical study in improving ADHD identification and treatment for females. Thank you so much.
Let's appreciate Faith, guys. So this is the Datathon challenge. This is the Datathon challenge that we worked on. By the way, how many of us participated in the Datathon challenges by show? I know, Timothy, you participated and your laptop crashed, you just said. So who else did? Yeah, do we have questions for Faith? Like if we have questions for Faith, just one question, like at 4:15, we should proceed with the next presentation. But yes, Esther, please unmute and just ask your question.
Hi, Faith. That was such a lovely presentation. I'm actually doing some sort of research on ADHD myself, but I'm using Max, not Max KDA. I think it's NVIDIA. Like, I've really tried to understand how to use Python for data analysis, but like, I don't understand it. Could you have like just beginner tips for me? Thank you.
I think I like that question, and that's why we are always here for it to, assist and support beginners in data science and data manipulation and machine learning. Faith, go for it. I
Okay,
also
hi.
have an answer. Yeah, go for it. Yeah.
Okay. So I would say the first thing, you've already made this first step of getting into a community that does discussions and forums on things like data science, AI, emerging technologies, and things like Python. But as a beginner, the first step would be to learn and really learn hands-on. So I would suggest Kaggle. I don't know if you're aware or familiar with Kaggle. Register an account there, and they usually have, there's a track actually for things like ML, AI, things like that, that are curated to someone's level of understanding and learning. So if you're a beginner, you can just sign up and take time to learn the basic variables, things like that, and then move on to understanding things like data sets, and then picking up skills and moving all the way to model building and things like that. But I would really suggest learning from Kaggle and also YouTube, things like that, and signing up for challenges like this, and yeah, engaging in communities that share insights and things like that. And also there's open source contribution. You can also try participating in open source contribution and things like that. And also you can try learning also from things like Geek for Geeks, Stack Overflow, things like that. But the first step on things like ML and things like that, I would really suggest Kaggle. Yeah.
Thank you. Thank you, Faith. I would suggest the same. And to just be specific, Esther, with your question around, particularly ADHD. So these challenges, once we work on them on Kaggle, so this was WiDS worldwide challenge, and everybody across the world worked on the same challenge. So if you can just go to where the challenge is hosted, again, on the Kaggle platform, you'll be able to see like thousands of notebooks in there. Some are very beginner friendly, especially with starter code notebook is usually very easy to follow, and you can just go start from there, right? So yeah, thank you very much. I think we just have to we have a very hard stop because the rains and everything. So we want to do it at like 4:15. So let's move to the next one. But I'm going to introduce now our keynote speaker. But meanwhile, if we can just stretch, stand up, stretch, and maybe grab a cup of juice or water behind as I introduce Dr. Elizabeth, who is going to give us a keynote talk. It's a 1 minute stretch. I think time is not on our end. So thank you very much again, Faith, for your wonderful presentation. With the guys, we are grabbing things so as we are coming back to our seats. Remember, there are those of us who are joining us online, and yeah, we have to be super, super fast. Let's come back to our team. Come back to your seats. Okay, so I'm going to introduce our next speaker, Dr. Elizabeth. Let's hurry up, guys. Let's hurry up, guys. Let's sit down. Okay, so Elizabeth, Dr. Elizabeth is our next speaker. Please, Liz, you plan the thing. You like so so Dr. Elizabeth is a lecturer at Dedan Kimathi University. She's AI researcher, she's developer, and she's a wonderful trainer. So she holds a PhD in computer science and master's in IT management and bachelor's in computer science. She's currently a lecturer, as I've mentioned, specializing in AI with a focus on AI in healthcare. Her PhD research develops a deep learning model for diagnosing, I don't even when of prematurity, and she is currently working on its real world implementation in hospital settings. Elizabeth is also an active AI developer, trainer, and organizer of numerous machine learning and data science conferences. Guys, let's welcome Dr. Elizabeth. Yay!
Thank you. Thank you, Millicent, for the invitation. And thank you to all of us for joining today. So I will try to walk around now that I've done a physical attendance so that all of us can see me. I was just looking at that photo there and I was smiling at it because people evolve. Yeah, so today I'm so glad to be here. And I'm also, yeah, thanks. Happy about the theme of the um, conference today. That is the future of women health, AI and data science to precision medicine. The doctor there is PhD, not medicine. So, and this is in computer science. But I've grown up just happy about medicine and interacting with health experts. Yeah. So my closest friends are doctors, are medics. Yeah. So you'll find me just going out to the hospital, not because I'm sick, but I just want to continue discussion about treatment, diagnostics, and what AI can do. So precision medicine works to support and the dimensions of trying to come up with medicine and treatment with the understanding that everybody's body is very different and everybody's body reacts very different to the same medicine. So the customization of personalized medical care. And that now links up AI at a close range because AI is utilizing data to be able now to develop or come up with solutions that more personalized or using data that is obtained from people. So the precision medicine has some key aspects that individuals' biology, which is very unique, will affect their health, or it has a correlation with health. And then it also supports and promotes individualized care, and then leverages us on data for diagnosis and treatment. And then now we bring in the angle of the power of artificial intelligence. And now AI, some years ago, my kids started making a joke and they started telling me, Mom, you know what? We've always looked at 2030 as a long year to come, because everybody back then was singing about Vision 2030. Then they started telling me, Mom, you know what? 2030 is 6 years, 5 years to come. I said, so they were saying that last year. They're telling me 6 years, 5 years will be at 2030. And we don't seem to be already living in the 2030 per se. So, but AI is here, and people are developing AI-powered tools in many sectors, some education, others in medicine and diagnostics. Other than teaching about AI, I'm involved in development. And other than development, I'm involved in, I do a lot. I'm also trying to work on AI systems that ensure that African languages are well represented in AI systems. And I'm also now very keen on ensuring that AI systems are developed responsibly and are implemented well. So if you talk about those spaces, you'll find me there. So AI has many power for early disease detections. I know Lillian has talked about this, and now we already know how AI can be applied. And then it leverages on the data sets for disease diagnosis. There's something I need to say. The data that you put on these systems has more power on the output that we get. When we began developing AI systems years down the line, most of these data sets were not obtained anywhere within African continent, because 6 years ago, Africa as a continent, I'm looking for the better word, did not have data publicly available, which is too huge for availability for development of these systems. And now when we narrow down, coming down to the health sector, where now data are something to do with security and things related to ethics. So the data that we use for developing these models will have an impact on the output. And someone asks a question about data. Where can I get data and things like that? And that's also another area that out on the looks, because if experts will work to promote availability of data, then we will work to ensure that we have systems that are not developed from worlds and is it imported or exported? Imported to Africa for us to customize. But having now the technology, the skill that we have when we're able to develop these systems using our own very data. So there's so many funding that's available for data collection. And nowadays, I'm not a fanatic of getting funding to develop an AI system to showcase and go out and say, wow, this system is able to diagnose disease A, B, C. And then I feel like I've done anything important. I want to be quick. I told Millicent I'll do 10 minutes or less. But nowadays, I'm more focused on, I want a project that even though even though I will not develop an AI system and showcase to the world, but if I'm able to collect data and I don't want to use the word fight, and work it out through to ensure that that data set is publicly available for other developers to use, I will sleep a satisfied person. So it leverages on the disease diagnosis, but using huge data sets. But take note, the data that you use as an impact on the outcome. So AI systems can provide better outcomes through timely interventions. And I know this is something Lilian has said. So now from data that has been obtained from people, we can get individualized care and be able to develop systems that are customized for treatment, um, for issues related to genes, genetics, obtaining people's lifestyles, and be able to develop systems specifically to meet their needs. I'm a software developer, both AI and non-AI systems. And I need to be honest that I find my customers lazy. So I founded a software developing company in Nairobi. So most of our customers will just come and they say, "Do you have a system that is ready for use?" You know, and most of the students are outside on GitHub and other platforms looking for shells that have already been developed so that they can just take out a few layers there, and train that model using their data, and they say, wow, I've achieved. However, I'll say we need to put more energy in having data sets that are unique, that are collected from by our own efforts and developed for customized to fit specific user needs. By that, we will be putting a lot of power in our brains to think and avoiding that copying of existing shells or existing models to fulfill a purpose. While teaching at the university, I'm able to grade a student more points if they just do a simple system that is theirs, developed from scratch, versus a student who gets these big already developed models and they put some data and they say, wow, I'm done. So I need some marks and the like. So these systems, again, that are developed from data, Lilian has said they can be developed and to suit different mental health issues. And then also AI has given us a lot of support in developing systems that utilize images for disease diagnosis, that is oncology and reproductive health issues. I find AI systems that utilize images for diagnostic achieving a high accuracy. Yeah. So we move next. So still on the benefits of AI and the like, and how they are supporting precision medicine. So AI is able to identify existing medical issues and even be able to predict existence of issues that people have that have not been diagnosed before. Yeah. So it can help health experts to even try to find out drug interactions and success rates. When you walk into a pharmacy or a drugstore, you will hear that expert tell you, if you combine this medicine and this one, that's a good combination. But that is what they were taught. That is the understanding they have. Now, can we have AI systems to boost the choice of combination of this medicine, taking in consideration of issues like allergies? Then it can accelerate treatment for women-specific conditions. I know Lillian has spoken about this, but trying to think through, let me use issues like baby development or pregnancy, for example. Every woman's pregnancy is very different. There are those who will have a very sweet time, good 9 months, and they're happy and aggressive and are active, you know, and there are those who will really go through stressful moments. So we can come up with applications that are not generic about pregnancy, that don't give you symptoms, issues that are generic, but are able to say, this is Elizabeth. Elizabeth will only realize that she's expectant during delivery day. Yeah, that is the day that, and actually the doctor has to call me and tell me, you know, we've just checked on your profile and realized that you're 10 days past your due date. That's when I say, oh, you mean I was expectant? Yes, you have to come. Yes. So how can we come up with such systems which are very unique to everybody? I've done a lot of projects. And as much as you keep on developing these systems, you will never feel like you've achieved anything. One of the system I've developed previously is we call them tiny devices. A kind of a device that is able to help mothers that are located in rural areas to be able to track pregnancy development. And that application is being used by some women in Marsabit. So if you can venture in research related to tiny devices that don't use too much resources and try to see how can we pioneer these devices and embed them to AI systems and to be able to support specific cases, pregnancy, hormones tracking, and things like that. Genomics analysis also systems can be used to predict treatment responses, but these are customized to individual cases. And then still again on AI, we can have these systems trying to provide data-driven insights for everyday's health management and the like. Yeah. So I began by saying that as much as AI is giving us a lot of, everybody's looking at it and saying, thumbs up, the technology is helping us, the technology is able, but we have work to do because the data that you feed in there, how you develop that model is exactly the output that you're going to get. I am always happy when I meet people who say, I tried, I failed. But how many people are able to step out and say, I developed a system and I want us to throw it away because it doesn't seem to be secure. So biased algorithms can create huge issues. Yeah. I like those times when people are saying, Elizabeth, this is very shameful. Elizabeth, we can terminate your contract for working for 4 months on a client's project, and the client has paid us so much, and time is up, and you're here saying that you cannot give us this system to deliver to a client because it is not safe. You don't feel like there's a safety component in it. Sometimes we do it. We call them throwaway prototyping. So I always like people who have that, and it's a personality you must gear in as a person, as a developer, to be able to go out and to say, I beg to be forgiven. I want us to throw out this system. I need more time. Patient data must remain private and secure. The doctor there I said is a PhD. And when I meet a medical doctor, I'm very submissive because their language is not our language. They understand data security, patient data security more than I do. There are sometimes they will tell me, can you walk away because we can't give you this data? And I will say, thank you. Yes. So data privacy, data issues is a problem, is a challenge, but data is available outside there. So we need a robust ethical and regulatory oversight that is going to span the systems, declare them as safe or not safe for use, and the like. So what next? I think this slide, and then I'm done. We'll have virtual assistants, virtual health assistants, and telemedicine. I need to be honest. I get so many chats, and then I look at them and just say, wow, I feel very inadequate because I'm a developer of AI health systems. And sometimes there are components I embed on those apps, sections of chat me, let's chat, like the one-on-one socials, one-on-one empathetic apps. And when I look at those chats that are coming, I feel very inadequate. I feel like I would have done a course on psychology and counseling so that I can be able to support the posts that are coming. But we AI is able to do that at the moment, and that will continue in the future. And then we have robotic surgeries and AI guided fertility treatments. As I said, I'm involved in many projects, and one of the current projects I've just concluded is on digital skilling for all citizens, especially in the country, because AI is here and AI is with us. So when the country says we want to regulate AI or promote AI adoption, where do we place the people in the rural areas? So there are a lot of digital skilling programs the government has come up with. And as technologists, we've been busy now teaching these people from the villages, not really about what AI is per se, but trying to build hope and trust so that when you walk to an hospital and you find a robot and you're told this is a robot that is going to do an operation, you don't panic and your pressure goes high. So this is not something to come, because in some hospitals, let me not say in Kenya, but in some hospitals globally, we have the robots that are set already, and they're collecting a lot of data, and there's a lot of work ongoing. And you'll wake up tomorrow and see a robot inside a surgery room. Then we'll have a lot of collaborations, which we still have for people from different sectors. So I want to encourage all of us who are seated in this room today, that don't just stick to your area of specialization and say, I'm a computer scientist, I have done community health, I'm a doctor. So you need to do a lot of collaboration. Empowering women through precision medicine, AI and data science provide a lot of empowerment, especially I've said on disease diagnosis. And then we need to also to ensure that there's a lot of inclusivity and equity. If you sit as a lady in your comfort zone and you just say, oh, I have a PhD, now I can just relax, I'm at the rooftop, I don't want to interact with people, I don't want to do research, I don't want to do publication, what is likely to happen? That does not stop any other person going out to do research. So if you talk about women specific issues, so I encourage women to be outside in the field, saying something and writing something. Together we can redefine women health. AI systems should be tailored in a way that is responsible. I think this is the last slide. So yes, that's the last slide. Fantastic. So should be tailored to be responsible. Do not develop a system that gives an output. And then when people question you about that output, you're looking at the system like it is the system. No, 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 no. You are the developer. You are responsible. So they should be developed to be responsible, and creating a lot of openness, transparency, trying to explain as a developer, why did I choose this specific algorithm in this development and not the other. Thank you so much. I am now done.
It's quite educative, a lot of insights. Elizabeth, thank you very, very, very much for a great talk. Guys, do we have like one question for Elizabeth? Like one quick question before you go?
Hello everyone. My name is Faith Gishuru, and I have one question for Dr. Yeah. I've been really keen to follow through your area of expertise since it's something I've tried and I've failed, and you said you like it when people try and fail. And one of the challenges I went through is when you approach these facilities or clinics to get access to data, and as you've said, you have to really work with them to understand the data so that you can be able to take what you need. How do you handle how vastly different clinics handle their data? Because you'll find that every organization or clinic take their data very differently. For example, if I can take the one you're talking about, pregnancies, like they'll have such a vast data, and sometimes they haven't exactly as consolidated it as you did need. So how do you go about that?
Thank you. So I will speak out of experience. My PhD developed a deep learning model for retinopathy of prematurity disease diagnosis. And what I learned is for you to be given the data, you must be a student. Like the person giving you the data needs to mentor you on how the data has been collected, how it can be collected, what is it for, and what is it not for. So, like for my case, we had to do like 6 months training, 6 good months, one-to-one sessions with the doctors. And not this is not data collection. This is a class. Sit down, learn. This is the data. This is it what for. This is how we collect it. So I'm taking notes. So when you when in those 6 months of interactions, if you don't appear like a student who understands the seriosity of that data, they will not give it to you. And then when they give you that data, they will tell you, this is how you should use it, and this is how not to use it. Some hospitals will guide that in that AI system, you can train the model and test the model using that specific hospital data, and don't merge it to any other hospital data and call it one data set. So they can even tell you, we're giving you 100 images, but these 100 images, train your model, test your model, but don't bring other images to this one, to our data set. So they are very specific. And they are doing that so that if the model has a wrong outcome or serious outcome, they can be responsible. Yeah. So it's tough because this is not data that is available published online. This is data that is available in a specific hospital. So they will put you in as a student sessions and training, and then they will tell you, they'll give you permission for merging or not merging with another data set. And they will tell you, can you produce a publication about what you've done with this data or what your model has produced? And then they will read that publication slowly by slowly. If they don't understand or if they feel like you've lied somewhere, they will tell you, pull out the publication and pull out that model. Yes, it's as bad as that.
Let's thank Elizabeth one more time. Thank you very much, Dr. Elizabeth. At this point, we'll rush into our spotlight talk, which will be delivered by Dr. Terry. So she is a doctor, into brackets PhD, and Terry is a medical doctor. So guys, we have everybody we need, and during the panel session, I won't even ask them so many questions. I actually want questions this time to come from the audience. We have medical professionals, Dr. Wamboy, we have Dr. Terry, and we have the AI researcher, and so many other AI researchers in here. So it's going to be interesting. So at this point, I'll invite Dr. Terry Moshiro, who is a medical doctor and software engineer passionate about using AI to transform healthcare systems across Africa. She currently leads AI-driven innovation projects in digital health at Intellisoft Consulting with a focus on low resource settings. She is a graduate of Kenyatta University School of Medicine and ALX Software Engineering, and previously worked as a Kotlin developer at Safaricom. So Terry's work bridges clinical insights and technology. So Terry will be sitting at the middle, like she's a AI enthusiast and she's also a medical doctor. It's going to be interesting. So Terry bridges clinical insights and technology, grounded in a strong commitment to ethical, inclusive, and locally relevant AI. She is a champion for African women in tech and strong voice for responsible innovation. Let's welcome Terry, everybody. So I'll just share her screen. Uh, Okay. Can we just double check if you can see Terry's slides? Faith, can you see Terry's slides? Thumbs up if you can see Terry's slides. If you're joining us online, otherwise we'll move without you guys. Okay. Are the slides visible?
Yes.
Great, thank you for confirming.
Thank you, Millicent. Good evening, everyone. Good evening to the ones online as well. I hope I'm audible. Thank you, Millicent and Sam, for inviting me back to the WiDS Datathon. It's a pleasure being back. I say being back because I was also present during the 2024 Datathon. And yeah, I'm really glad to see the progress that the WiDS community in Kenya has made. I think when Catherine, the one who gave our opening address, was talking about such meetings, I'm a living testimony, really, for the beauty that such communities bring, or the benefits, I would say, because where I work now at IntelliSoft Consulting was from last year's like last year's meeting, like this one. Some of the other person who was in a panel where I was speaking at was working at IntelliSoft, and it was literally a stars aligned moment. So coming back again this year is truly a pleasure for me. As Millicent has introduced me, Terry Mochire. Grateful to come after all the other previous speakers before me, because my work has really been made easier. For example, I have learned that I should probably say that the doctor in front of that is medical, not PhD. I wish it was PhD, but yeah. I'm a medical doctor by training. I currently work in the digital health space, which means I merge tech and health, essentially. My key passion area is in artificial intelligence, and that's what I do on a day-to-day. The reason why we are here today is to have, okay, let me go back, to talk about health equity, with a focus on where does artificial intelligence come into play when we're thinking about health equity, right? So I'm hoping that in the next few slides, we can really understand the inequality that exists in healthcare when we think about women, and then the possibilities of artificial intelligence in this space, the good, the bad, the ugly, and what can we do to prevent the ugly, mitigate the bad, and get the best out of the good. So why does this even matter, right? in the African context, not actually really in the African context only, but in health generally, women bear the greatest burden of preventable disease. So think about cervical cancer, right? This is a disease that has been studied. There is vaccines. There's vaccines against it. There's treatment, and yet every single day we know people who die of cervical cancer, right? Think about breast cancer. I think any advertisement around self-inspection, how often you should go for a mammogram, and once you get diagnosed, the treatment modalities that are available for you, and yet every single day we lose someone to breast cancer. And those are two examples. We could go on and on and on and on. And those are the cancers. There's still the infectious diseases. There's the, why is it that when a woman gets pneumonia or a TB, or they still die from these diseases in a greater proportion to their masculine counterparts or their male counterparts, right? And when you think about equity as a thing, like as a right? It's not only a moral issue. When you think about it, it's not only morally right for people to get equitable access to healthcare. It's the foundation of societies that we live in. Like, really, if in a society everyone is able to get healthcare, then you have a healthier, like generally in that society, if maybe your health percentage was at a 50, and then now everyone is able to get healthcare access, you probably raise that 50 to 60 or 70, right? A healthier society is a more economical society, is a happier society, right? So it's not only morally right, it's also foundationally right. Like, if you're a politician, for example, and you're looking to have, and your goal is to have the happiest people, then healthcare access really should be something that is at the top of your mind if it's not yet there. I mean, we can talk about that. So that's why it matters. So what is the opportunity for artificial intelligence in this space? As the people before me have gone, I really will not deliberate on this slide because we've talked about where AI can fit in healthcare. Excuse me. But for women, and particularly women in low resource settings, for me, these are the three areas that I think would have the biggest impact. Because for the diseases that I've talked about, like the cancers and the TBs and the cancers and the TBs and what have you, the earlier you are able to know this thing exists, the better your treatment outcomes. And detection is a whole range of things. There's the imaging aspect, right? Like they're coming to the hospital and, I don't know, doing your pap smear, right? But before that, you as the person at home or the woman at home needs to be aware that I need to go for a pap smear maybe every 5 years or every year, depending on my age. So the early detection, already there's gaps in detection because there's knowledge gaps, there's infrastructure gaps, there's maybe like the way the health system is situated, the way you move through different hospitals or whatever, there's gaps there, right? So artificial intelligence, by saying that we can do early detection, maybe it's, instead of thinking about a very complex system and an algorithm that it does image analysis or whatever, maybe it's an artificial intelligence that fixes the knowledge gap in the women at home. Maybe it's an artificial intelligence system that fixes the steps that you have to follow through when you're going through health system to get to the early detection, right? Next thing, predictive modeling. for example, in maternal outcomes, I think a speaker before me talked about, I think it was Lillian, yeah, talked about preeclampsia as a disease in pregnancy, right? If we are able to know from the start that Terry has a risk today, non-pregnant Terry has a risk of developing preeclampsia from the start, then we are able to monitor and follow her journey and have better outcomes because we were aware, right? Then remote support and monitoring. And this comes in both, like in the, for example, in the postpartum depression that was mentioned earlier, or even women who are diagnosed with chronic illnesses and have to go through like treatment for a long period of time. Maybe you are a known diabetes patient and you are at home, but then we need to monitor your sugars over a long period of time. I promised I'll not take too long on that slide, and that's exactly what I've done. But then there's a catch to all of this. This can only work, all this that I'm talking about, it can only work if it is designed with women, for women, and by women, and not just women, African women, right? Because in the hierarchy, like in our differentiation and in our segregation and in our like vulnerability, when you go down, when you rank or classify the human race, African women usually are the most sidelined of communities. So if you were to think about the misrepresentation or the marginalization, yes, that's the word I'm looking for. The marginalization in data, it's like you start from Black people, and then you're not only Black, you're Black African. You're not only African, you're an African woman. You're not only an African woman, you're probably an African woman in an marginalized community, right? So like you probably are not represented in this data set at all. So if this is to work, then it has to be, as Dr. Elizabeth had mentioned, you probably cannot pick something designed for a white woman, and a white woman's breast cancer may be charging to suit an African woman's charging case. Yeah, so that's exactly brings us to this slide and the first point that I have there. These AI models that are trained on data that exclude African women cannot be used in our setting. I'm impressed by datathons like this, but truly the data set that you work on a datathon like this is not a data set that represents Africa. So I appreciate what Faith did to talk us through the solution, but at the end of the day, maybe brain connections and ADHD diagnosis and all that she talked, maybe we would have a different conclusion if we did that on an African data set, right? So that needs to come out very clearly from the time that you're designing your AI solutions. It's who are you building it for? I mean, at the end of the day, sure, you can build the model and export it. And maybe that will bring you income, sure, but are you really solving the problem at home, right? So, so what does this context appropriate or equitable AI, as we want to call it, look like? It addresses the real gaps in the current systems. So whatever AI system you are building, right? Where would it fit in the current system? So you're building an AI system for ADHD diagnosis. It's where does it fit in the current workflow of ADHD diagnosis, right? In the current workflow, maybe someone comes in, they go through consultation, they go through maybe an investigation and tests and whatever, and then the diagnosis is made. So where in that workflow does AI fit in? Because it can't, most of the times it cannot do the entire thing. It's probably being fixed somewhere. And if it's being fixed somewhere, it's because there's a gap there. Like there's an improvement that could be done there. And if not, like if there's no gap, if it's not changing, if it's not if making the system or that workflow any more efficient or any more accurate or any more, like it's not doing anything better, then probably the costs and the risks are not justifiable. Cinder. And it's at the end of the day built with inclusive data. I like that we are finally having these data conversations. Even today, a lot of questions have already arisen when we think about data and data in healthcare particularly. I think to also chip in into the questions that had been asked earlier, data in healthcare, as Dr. Elizabeth had mentioned, is too sensitive. It's too sensitive to just be as publicly available as we would wish. And I think instead of trying to make it that publicly available, is to work with it in the holes that it exists in. So if you're building a system for, just exactly as she's mentioned, if you're building a system for retinopathy of prematurity, and then you probably need the data set from an eye clinic, then work with an eye clinic, right? From the start. Therefore, there you have access, instead of saying, I can't build this model because I don't have an inclusive data set, right? Like I know the process is tedious. It's not cute to get data sets from these hospitals, but with things like research protocol approvals, like there are ethical bodies that do the ethical reviews of your research and then give you approval to get the data set. So there's a review body, you write your research proposal, they review it, and what do you want the data for? What do you want to do with it? And then they give you an approval. And with that, it almost, now when you're approaching your eye clinic to get images, you have sort of a validation, right? Like a KEBS approval of some sort that whatever you're doing is ethically right. Yeah, so what must we get right from the get-go to get to this equitable AI where we balance out the risks and the benefits? It's co-design with the people we have in mind. If we're building systems for women, then when you're designing your women solution, it should probably have a women voice, right? It can only have a women voice if you bring them on board. You bring them on board as in user tests or in user design approvals, in your engineering team, in your leadership team, in your piloting and testing team, like at every step, then I feel like it would be harder to lose, like it would be harder to miss a design concept if there was a woman who checked it and be like, that's a period up, yes, but then you're not allowing me maybe to log my possible ovulation date or something, right? Like you're missing something that is very crucial to me as the user of the period app. So same thing for artificial intelligence as well. I know maybe majority of the people in the room are, okay, I really don't know. Let me not say I know. But if you're coming from a purely engineering background, I understand the complexities in understanding the health background, right? So then instead of assuming that you're building, I don't know, I'll still reference what we're building today, maybe an ADHD model. Maybe you're building something that in the clinical workflow would not, everyone would be like, oh yeah, that's nice, but like, I don't think we need it. It's not relevant for our setup right now as a healthcare system in Kenya, right? So have the physicians or have the people who understand the ecosystem you're trying to build into. I'm not saying, I don't think everyone will build into healthcare. If you're building into finance, for example, an AI model, you probably need someone in that side to tell you that the outcomes of that model do not make any sense or are not relevant or are not useful. You'll have a model as a project that has an outcome, but is not being used at all. Then, as has been mentioned already, ethical safeguards and policy frameworks. So I mentioned this not only as things to get right, but also as possible opportunities for people to plug into. So for the women in the room who are not engineers, doctors, whatever, put yourself in places where when people are designing AIs for women, they'll be like, oh yeah, Terry, I think it would be nice to pick your brain on ABCD, so that you're giving your perspective not as an AI consultant, researcher, or whatever. It's just simply because you're a woman, right? If you're a physician, you also don't need to understand the tech. Is put yourself in places where if they need to understand, they reach out to you. Ethical safeguards and policy frameworks. Put yourself in a place where maybe you're the one who evaluates. Like that's all you do. You look at a model and evaluate it on things like bias, explainability, latency, things like that. So you're not only you're not the one who builds the model, but it's an opportunity for you to evaluate the model as well. Sustainable financing and partnerships. Unfortunately, for AI in healthcare right now, at least most of the projects I know, they remain in the proof of concept stage. You build a model, sure, it works, but now we have a sort of a repository or a basket where they all go to die. Then we look for new financing to build other models. And once the financing is over, they go back to the same basket and die. They do not have longevity past the original funding sort of life cycle, because they're not sustainable from the get-go. You're building a model where one inferencing is costing, say, 100. Okay, that's ridiculous, but like, say, 7 USD, and it does this maybe like 1,000 times in a day, right? Who is going to pay for that? You need to think about it from the start. So what would I think is the vision? An Africa where we're not only consumers of frontier models from the West, where we are able to build our own systems for our own problems that work for us. I think about the way M-Pesa was born. It was an African problem to not be able to travel from one place to another to give someone the money that they require. And it was an African solution that fixed that. It was an African solution that leveraged on the tools that Africans already had, which was SIM cards, to transfer the money, right? So maybe we do not need to have, I don't know, chatbots on websites, because we are rarely on websites to, I don't know, interact. By the time you're getting on a website, you know what you want. I'm not saying that we don't. I'm just saying maybe it's not an African problem, and trying to implement it in the African setting, maybe that's why it just does not pick the same way. For example, like I'm just giving that as an example. And at the end of it all, for us to be able to design these things for women, we need women in them. So women need to be the owners of this data that you're talking about that represents African women. They need to be the engineers, they need to be the decision makers, they need to be the policy, they need to be the evaluators. Like, you're not missing out on any step of this development cycle, so to speak. So finally, like, what am I really saying is, as you're building your artificial intelligence system model, actually, not only that, like, as you're building anything, build with context. Understand where this thing is going to fit into in the bigger picture. Because like anything, and it does not exist in isolation. So wherever it will fit in the bigger picture, you need to understand the bigger picture, so that you're not building things where, I don't know, for solution in Turkana where they don't even have maybe network connectivity to begin with, right? It's as you're building then an AI model that will be used in Turkana, you account for the fact that in Turkana, this is the setup. And for women to be in the center of this, we need to invest in the women from today, actually from maybe yesterday, maybe, so that we have women leaders, women researchers, women innovators, women designers, women who can speak up and say, that doesn't work for me, right? And it's up to us at the end of the day as engineers to not build tools that will be another division line, like another fault line, for example. Like when mobile phones were first invented, they were a tool that was only accessible to the wealthy. But as time has evolved, now we are making smartphones that are affordable. So how can we reduce that gap as much as possible, essentially, right? That is our responsibility, to ensure that we're not deploying models that widen the already existing gap. Yeah, thank you, thanks.
Guys, let's appreciate Terry. Terry, will you take like one quick question for Terry, then we can just move to the panel. But yeah, thank you very much. Putting women at the center, like this is women's health we are trying to improve. So then if we put them at the center, then we are going to get there in terms of improving their health and stuff like that. So I really enjoyed your presentation. Thank you very much. And maybe instead of even asking Terry question based on her presentation, why don't we just ask during the panel session? So here, team, if you can just help me like pull these seats so that we have a quick panel discussion, and then guys, so that we can move to the next, right? So yeah, thank you very much. Thanks so much, Jen, for helping out. Oh my gosh. Yeah, so here in the panel, we will have Dr. Wambui. Dr. Wambui is our medical specialist here. She's a wellness manager at Britam Health. She's public health specialist. And we will have Dr. Elizabeth Mutiwa. We already introduced her, and we will have Terry back. Unfortunately, Lillian is not going to join us. She had to run. I wonder if Faith, you'll be able to replace Lillian.
Okay, that's fine.
Yeah, so that we have Elizabeth and Faith, who are AI specialists, and yeah, Terry and Dr. Wambui, medical um, experts. So our guests, please, the floor is all yours. Can we please appreciate our guest speakers as we come? Thank you so much for coming. And for this panel is going to be really, yeah, no. Brian, where did we get the other? Where did we? Yeah, you can assist us with that. And Faith, you will have to turn on your camera if it will really help us. So yeah, in this session, maybe just in 1 minute, if we can just do a round of introduction, like in your own voice, and like, yeah, I've just told them that you are AI researcher and she's a medical doctor, Terry, and Dr. Wambui. So yeah, quick.
Elizabeth is my name. Okay. Okay, great. My name is Elizabeth Mutua. My PhD is in computer science. I'm both a developer as well as a trainer. Thank you.
Hi again. My name is still Terry Mochire. I'm a medical doctor. I work in the digital health space. Yeah.
All right. Hi everyone. Dr. Wambui Mutura is my name. I can see quite a number of familiar faces. That tells you I'm back. It's always a very humbling experience. Millicent and Sam, the whole team, to get this invite, because as I say, I might be the least data savvy person and digital tech savvy person in the room, but it's always a very good learning experience. And I think the previous speakers have talked about collaboration, how all of us can plug into this whole discussion. So I champion preventive and promotive health. Public health is my passion, and very happy to be here. Thank you.
Thank you so much. And just hold the mic. I wonder if Faith, are you with us? Or we can just ask you questions, if any. Okay. Okay. It's usually hard coordinating panel session on a hybrid mode. So yeah, Dr. Wambui, our subject matter expert, I think I'll start with you, since you know this guy, they have spoken before, and like you haven't. So I think my first question for you is, you know, it's just disappeared. So as someone working across, public health and private health sectors, what role do you think data and of course AI can play in shaping more effective and inclusive uh, and inclusive healthcare practices?
All right. So thank you, Millicent, for that question. I think the best way to tackle it is first to understand what a health policy is. So a health policy usually is the beginning of a health intervention. So this means that, let's say, for example, someone sat down and realized there's actually a very high rate of maternal deaths in Kenya. And these are people who are trying to think about how can we tackle this. So a health policy assists us in making the decision on what health intervention are we looking at, what problem are we dealing with, and what actions do we need to take, and what impact are we expecting. So basically, this is like a brief. Someone actually just does this brief. So to the main question on how data and AI can assist in us developing good health policies that work actually, is one, I'd say, first of all, there has been the challenge of the lack of data. Like, we generally lack data in the African context, in the Kenyan context, in the African context. So what this means is we sort of tend to plug and play from the West. So we look at, let's say, US, what have US done with regards to maternal health? And this is the kind of things that we include in our policies. So what challenge that brings in, as the rest of the speakers, everyone has alluded to this fact that us not personalizing this data, this is not our data. Whatever happens in the West is very different from what happens in currently in our context. So one of the things that data can assist us in, one, would be to identify the problem that we are dealing with. Different regions have different problems. So when we have this data, then we are able to get to know exactly this is what we are dealing with. Data, again, assists us in knowing what actions to take, because we might implement an action. We might think that for us to solve maternal mortality in the, let's say, in the northeastern region, we might need to, let's say, make our customer journey in the hospitals much more seamless. Those are the kind of actions that we are going to take. Or we might think we might want to maybe just implement something else that we are borrowing from a different region, forgetting that, yes, some of these women in, like, let's say, the marginalized areas are not even coming to hospital. So how is making the customer journey at the hospital level more seamless going to solve the problem? So that's why you see Kenya has been accused of having very good policies in the books, but the implementation is where the main challenge comes in. And then data also utilizing, as I conclude, utilizing data and, of course, by extension, AI, to actually look at the impact of what impact has this policy had on the actual problem that we're trying to solve. Why is because sometimes we do have policies. Let's say a policy like, let's say, the Linda Mama. All of us know about Linda Mama, right? So Linda Mama was to come in and bridge this gap of and try and help us solve the problem of maternal mortality. But when you look at, and this was probably rolled out in the country and women were enrolled onto it, but what you realize is our maternal mortality from the most recent, Terry, you can attest to this, from the most recent WHO, or it's the maternal mortality rate in Kenya has actually gone up. It's very sad that people came up with a whole policy, we implemented with this, but the problem you're actually solving has gotten worse. So AI, at the end of the day, data, and then of course by extension AI, and what this does should be the anchor towards all our health policies, because once we don't have this, then we run the risk, of course we're all already in that situation where we have very good policies on paper, but with the implementation and the impact you're having, it is not really making sense.
Interesting, amazing. Thank you very much, Daktari. So many ways in which we can use data, Dr. Elizabeth. So here we are talking about, precision health, right? So you as our AI specialist and engineer, right? So in your view, what does precision health, or what does precision mean in AI diagnostics? And how can we ensure that the models we are training remain more accurate and even more equitable, especially in the African setting? And this question, I think, Terry, will also help us because of how you are trying to, ensure that models actually generalize for low resource settings. So like precision in that setting.
Thank you. I think so far we've already spoken about what precision medicine is, and our AI is coming in to ensure that we have systems developed for diagnosing diseases and to support people, promoting individualized type of care. But now there is that question that is coming in and prompting something in my mind that we need to be very active, especially us and people from Africa, in collecting data from our own within Africa settings, so that we can develop systems that are using data collected from this continent of Africa. But the only thing I need to add on top there is, as we are the developers, and the data collectors, majority of data collectors are AI experts or people who have some basic understanding of what AI is, or technologists. But what I need to add on that is we need also to involve the community in data collection. They need to be part and parcel of the data collection process, and whereby try to bring them closer to the development steps, early development steps, so that they can understand what data are we collecting, what systems are we developing, so that when we are done with the development, AI systems for assisting them in disease diagnosis will not be a new thing. So I feel like when I go outside to collect data, I need now to bring the non-tech, the people who've not gone to school, the people in rural areas, and try to remove the tech part in me and involve them in the data collection process, stories surrounding the data, stories about AI, so that even as we now one day launching a system on our television stations, there will not be resistance. They have already been involved. So as we're collecting data within the African continent, I will say that there is a stronger need of involving the non-tech or the people within the communities where we're collecting this data from, so that they are part and parcel of the entire development process. Thank you.
I think Terry really Terry talks about this, and especially involving women. If at all it is precision health for women, then involving women in the development, design, and if you cannot train a model, like be part of evaluating it at least, right? So, yeah, thank you very much, Terry. Do you want to add anything on creating more accurate and equitable systems for health?
Yeah, very briefly, actually, because Dr. Elizabeth has really mentioned, has really covered it very well. So the goal of precision medicine is to build, or rather to have medications or healthcare that's as tailored to the person as possible, right? And I think before you get there, it's you understand, not to marginalize, but to understand the differences between Terry and Dr. Wambui, right? Like that has to be that has to come out very clearly, so that we say that this medication works for Terry and not Dr. Wambui, because Terry is built like this. And you can only understand a people if you are able to like like you're able to evaluate them across this maybe very layered characteristics. And what I'm saying by this is, then you need to come to the level of the person to really understand what differentiates any two people. And while building artificial intelligence for very personalized reasons between maybe Terry and Dr. Wambui, maybe that's a future that's maybe 10 years away, right? But what is closer is maybe Terry and Wambui, what are their similarities, and can they fall within the same cohort? And if they truly do not fall within the same cohort, then maybe just don't build AI systems that cover and that blanket these people together. Is understand the different cohorts that you have and treat them as such, different cohorts. And when you're building them, to localize to the cohort that you're building for, instead of trying to make it a blanket solution for bigger people, maybe because it has better income or is a shorter route. Yeah.
Precisely, yeah. Yeah. Okay. Just to involve Faith in this conversation. So, Faith, I'm just going to throw a question on you, but before you answer it, I think I'll hand the mic to Dr. Wambui. So, Faith, we are training models now for precision health, right? A lot of people are also wondering about AI replacing jobs, and this is going to be like across all sectors, including healthcare. So, how can we ensure that digital health solutions truly augment rather than replace, the clinical experts, the medics, right? But then, Daktari, so in your field and from what you've learned across, especially for women's health, what have you seen are the most pressing health issues that are affecting women, especially here in Kenya, right? Because all of us here, we are here because this topic was quite exciting and we want to, get to understand like what are exactly these issues or healthcare problems that are affecting our women currently, and how can we use data, right? So first of all, what are these pressing issues? And given a solution, like, and now you've said most of these solutions just like they remain in books and notes. So how do we ensure that we implement the solutions we develop? Those are so many questions, Dr. Wambui, but start with what are the most pressing issues that women are suffering from currently?
All right. So I'll tackle it based on what I've seen and based on the areas I've had the privilege of practicing in. When you look at the lower resource settings, that is where I had my internship. One of the main challenges, of course,
Actually, maybe you and it came from Terry as well. We need a definition of low resource setting. Yeah.
so low resource settings, I'd say majorly we usually look at the rural areas. Why we say these are rural areas? Because most of the time you'll see they are resource constrained areas. Any area that is resource constrained actually can be termed as a low resource setting. So here we are looking at rural areas in Kenya, especially, the disparity is usually very big. Of course, in the urban areas, then we are looking at the informal sectors, informal settlements. Those are the areas majorly that we look at and refer to as the low resource settings. So from the public, I think the public health sector is where you're able to actually see a lot of what women are going through. One of the main challenges, of course, revolves around reproductive health. So reproductive health, this we are just looking at from the get-go. And here also just looking at the whole life cycle of a woman. So women don't just become women. They're not like adults. We come from being a young girl, then there's the adolescence, then there's the premenopausal women, or the adult women, then there's the menopausal women. So the major challenges that are facing these different age groups are maybe a bit unique, but for adolescents, what are we looking at? Majorly, it would be around menstrual issues. So these are menstrual disorders, what are just the reproductive knowledge. These are the kind of conversations around contraceptives and such like. Then the adult women, then we come into the issues of maternal health. Then this is looking at issues around pregnancy and all the resultant complications therein, issues around childbirth. Those are the main issues. Then in the menopause continuum, then of course there is the issue of menopause. And menopause has become a very big issue in society currently. Why? Because it's something that has not been talked about a lot. And this is a challenge that almost all women, it's sort of in a life cycle. Like a woman was an adolescent, they were in the early adulthood, they gave birth, and now they are going into the menopausal area. So those are the main challenges that I have seen, things that are a bit unique for women. But a lot of these challenges, especially in the low resource settings, and of course we can't forget the cancers that we deal with, that is the cervical cancer being the most common in our context, but of course also breast cancer comes in. But all these challenges, and I think Terry, there is a very important thing that she alluded to, that sometimes we are looking at being engineers or being specialists in this area. We are looking at very complex solutions, very complex. What models can I build to solve a very complex issue? But what you might realize is actually the main issue might be knowledge. Just knowledge. Like, I'll give an example of where I did my internship. That was in Mwingi, which is in the Ukambani region. We used to have a very big challenge around the lack of knowledge around contraception. So these are women that would see it's a woman who is at 35 years, but they've come to deliver their 7th child. Or we are seeing a very young girl at 15, 16, then we are just seeing these people coming to the maternity ward. So just implementing a class that for all these women who've delivered, we give them a class on contraception. What is contraception? What methods work? What can you get at this point when you're coming for clinics? What can you get? Then we actually started seeing an increase in the knowledge around this. And these are women who we're not just training them for themselves, we're training them for the community. So when they go to their groups, they're going to educate each other. So you see, if you are developing a model for that, you'd not, well, I'm not an engineer, but I am assuming that it would not be very, very complicated as opposed to other. But you see the impact that you'd have. So that's what I'm saying is sometimes we don't have to look at very big solutions. The impact we might have just needs us to understand the situation on the ground again. Don't borrow things from the West and assume that the impact is going to be the same. Look at your context, use data from your local context, and you'll be able to have impact.
I think I love it. And I love the challenges you've talked about, and you've also touched on early pregnancies, which, currently in Kenya, I think news is full of like our young girls, getting pregnant because of lack of knowledge. So, and I agree totally with you. Like, we don't need big models, chat GPT, Kubwa. We just need like information. And by the way, this is the challenge to the community. Currently, we have like, this generative AI, right? Us, we can use them in our phones, but people in the low resource, now I understand what low resource means. People in low resource probably don't even know what that is. How about us who we know, we extend these to them to create like awareness, right? We also have another one that mental health, right? It is a huge issue. It's affecting so many of our young girls and also like everyone. And yeah, we just need like some knowledge. And how can we do that? So how can we ensure like, okay, let's say we worked on this solution. How do we make sure that that solution like gets to the user? Because yeah, that was also the second part of.
All right. So I think that's also a challenge I've seen quite a bit from where I sit in the wellness department. We see a lot of solutions coming in. Oh, we are doing this for pregnant women. This is a solution that we are giving. But the main challenge, well, I could say of also it stems from also the development. Like when you're developing and when you're coming up with this solution, have you involved the people that we are looking at? Because when you sit in Nairobi and you identify a problem, you will solve it based on your context, right? So you've not gone to, let's say, Mandera or Kibera to actually understand this woman's context, this woman's life. How does she? Well, what is her day to day? Where can we? How can she plug into these solutions? So one of the main areas I've seen for even develops and even the challenge being for the team here is when you're developing, I think you have to have the end in mind because so that we have scalability. Scalability is always a problem. And I think when you think of something with the end in mind, let me assume that I already have this solution. How am I going to trickle it down to this woman who goes to the farm in the morning? She's pregnant, she's going to the farm in the morning, she's coming for lunch, and then she's doing her other chores in the evening. Because I usually say every time that we have so many solutions. Like let's say in Nairobi, I could think of so many things I have seen around AI and what just the solutions that we are seeing. But when you go to the rural areas, when we go to like, let's say my grandmother's area, they've never even had. They're still pregnant. They're still the same pregnant women that are there. Our challenges are there are still people who are going to get preeclampsia, there are people who are going to get labor that when the time is not yet. But you see, the solution that we've created is just looking at, and I think it's a context issue. I think, Millicent, that would be the long and short of my answer for this, that when we are building from the word go, have the people at the center who you're building for. Yeah.
I would want to pass the mic to you, Terry, because in your presentation, I think I really loved your presentation. So the design of AI that involves people, basically what we would call context appropriate AI, something that would help us, have everybody in mind as we develop this solution to the end. Like, would you just describe to the community, like the process? How can we best do that?
So, yeah, that's a very good question actually, because sometimes when we think about then context appropriate systems or context appropriate AIs, then sometimes you feel intimidated to be like, okay, then I will never understand the lifestyle or the day-to-day life of someone in Mandera. And why? Because I've not lived in Mandera, and maybe being in Mandera for a week will not allow me to see what Mandera fully is, right? But if you break it down, it kind of makes it, at least you have a step by step on what to follow. And I think we could go through the entire process and whatever, but I think the beginning starts with understanding the problem that you're building the solution for, so that you're not building a solution for a problem that does not exist. So that I'm selling to you a solution where I am the one who's creating a problem you didn't have, so that I force the solution in your. Yeah, it won't fit. Like going back to the question that Dr. Amboy has just answered, that like what governs adoption is if truly I was having a problem to order a taxi, I would have to go downstairs and walk to the cars that are standing somewhere and negotiate price and find something. Like that's an existing problem. So if I bring a solution where I'm able to, call a cab from my phone, then adoption is almost automatic, right? So I think for me, building artificial intelligence in healthcare is plagued with problems. Like from the knowledge of the people who seek healthcare to the practice of the clinicians who actually perform healthcare, that entire journey is plagued with problems. So instead of sitting and coming up with your own problem and fixing it, then understand one problem and I think there's also something about the ease of the solution that you bring in. Because sometimes, yeah, the solution that you have, yeah, it works, but like it's adding another new layer of complexity into it. So make it as almost as dumb friendly, if I could call it like that. Okay, maybe not dumb, but dummy. Yeah, as dummy friendly as possible so that it integrates into people's lives and their day to day without having to have someone change their lifestyle, right?
I think, yeah, and I think implementation can just flow, right?
Yeah,
They won't see it on papers anymore. Challenges. One of the biggest challenges we've been having, especially now that we would like to even try and deploy solutions for women's health, is like this data. And you talked about data, by the way. So like, would you touch on like some of the challenges you faced even in developing solutions? So you'll just try and tailor it to our to our theme for women's health. And how have you tackled them? Because I know the challenges you went through are simply the same. There are always the same challenges in developing AI solutions. So for women's health. Okay, Faith, I almost forgot about you. I'm sorry. So you are next, Faith. Don't go away.
Thank you. So I need to say that health is very sensitive. We don't have anybody here who will go in a surgery room, for example, and they are being told that the surgeon, okay, the person to do your operation, this is the first operation they are doing. You will walk out, think, and come back. So health is very sensitive, and that is a human being. What about a system, a robot? So the challenges are so many. They're ranging from development of system challenges, scarcity of data, having people with the right values, life values. I've told you cases of where someone can stand and say, crucify me. I'm ready to go to jail. People who have that capacity are rare to find. Trying also to run away from greed. People who will be strong enough to say, we are not releasing this system, we will take care of the costs penalties for delaying user systems. And then also the challenges are too many now, building trust with the clients or the people to use this system. Right from how do you believe this application now that we're talking about artificial intelligence? And the first people, I want to use the good terms, the first people to fight AI systems are not non-scientists, are usually scientists. Because yes, it is not like a easy thing for me to do, to co-opt a medical doctor to AI system development, and we do it quickly and release it to the market. No, it's usually tough because they have not gone to school to learn how to treat someone or to do something. When they were in school learning, those ethical values, those do's and don'ts were instilled in their entire system, such that when we go now to the development room, they camp somewhere in the corner, and we camp somewhere in the corner. And when we meet during development, they tell us these are the medical terms, these are the medical rules, these are the do's, these are the don'ts. So we are sharp in developing, but a project may take longer than it is expected. A project might be very nice, but it will never eat the market. Not because it's not safe, not because it's not useful, but because to the people, not the users, to the scientists, the medics themselves, they are saying, no, we still need to, we still need some to be convicted that this is ready for release. So these are some of the challenges. And then we navigate to user challenges. Now, user challenges need, who else has used this system and they were successful? You have a case, a human being who can say, I'm a beneficiary. Okay, nice. And then my doctor is so and so, has he approved the use of this? Which hospital, Now, we are not talking about people in the rural areas. We are talking about learned friends in urban cities. And when we get there, it's no longer profits. It's trying now to serve the society. And it has been tough, it is usually tough. But what I will say is, I know we are living in a country where I don't want to use a term like everything is possible. But I will say that as we develop these hubs and put them in the market, in the area of health, health is not like education. Education, we can beat about everything. But in the area of health, we need to be very serious and sensitive because we're talking about the lives of humans. So all these are just the challenges that we navigate through in development, in the use, and pushing these products in the market. And now there is a success story, and that will be my last point. The success story is the systems that we have developed together with medics, and they are already being used in hospitals by those medics or in those hospitals. So when you go there for consultation or for treatment, they may not tell you that this is an AI-powered application that was developed together with this expert, but they are already there in use. And from time to time, I'll visit an eye clinic and just to find out, is this application still in use or did you throw it away? Yes. So the developers, to us, as far as AI is concerned, money, we forgot about it long time ago. You put money or profit as the go-to thing, you will not go anywhere because AI is still a new thing and health is very sensitive. But joy comes in when I know that I have system A in one hospital, I have system K in this hospital, and it's still working. And I know now, when now AI becomes everything in the market, I'll be able to give examples. I'll have places to begin with and speak about now the history and where it is being used. Thank you.
Thanks so much, Elizabeth, for that. Faith, would you come to the mic and talk about the question we asked you? Are you there, Faith? Okay, if Faith is not there, I
Yes,
think
I'm
I'll
here.
just. Oh yeah, so you were to tell us something about AI as augmenting but not replacing
Yeah.
us. Replacing
Okay,
intelligence.
so
Yeah.
we have to shift the conversation from what jobs is AI going to replace, to how are we going to evolve these jobs to accommodate or collaborate with artificial intelligence. We have to take steps like, for example, in healthcare, you have to upskill these medics and doctors in order to enable them or capacitate them to be able to use these AI systems to efficiently do their work. So we are looking at it from a perspective or from a point of enabling them, or giving them more enablement to enable them or to help them in their work, rather than really having to discard them and employing AI. Another point is also having a human in the loop kind of a design, where AI can do particular things, but when it comes to critical decision points, like in AI in healthcare, we have to have a human in the loop to make such major decisions, rather than really leaving or giving AI an entire preeminence to do such. And then another thing would also to be looking at AI ethics and things like that, and policies. So if the government and NGOs were to look at artificial intelligence as really a helper, and demarcate points, or rather boundaries, where AI can and AI can't cross. So for example, in healthcare, AI can be used to gather data, process this data, but giving AI, a full control, for example, in things like surgery and things like that, that would be a bit tough, or rather, it would raise ethical issues and things like that, because also human beings would not be comfortable leaving AI to work on them fully. So most speakers have taken examples on maybe things like menstrual health. There are apps which maybe collect such information, rather than really having your doctor keep a diary for you, writing your days and stuff like that. So if we use these apps to do stuff like this, and then a doctor would come in and tell you, based on the dates that your app has now collected, these and these are maybe the contraceptives that I can recommend for you to use. So we'll have to look at AI really as an enabler, and not really as something that has come to replace people from their jobs and things like that. Yeah, thank you.
Okay. Terry, what's that?
Yes, I wanted to add something.
Have a second.
Have a second. I'm not a medic, but I'm a patient. I'm a client. So yeah, I always classify doctors into two groups. The Google doctor and the learned friend doctor. When I sit before the Google doctor, I will tell before they say anything. Because the Google doctor went to school to get a certificate to get money. And when I say I have an headache, their computer is there and they are typing and Googling. And because they are not serious, AI will replace them. But I have the doctor, the learned friend, who was an entire pharmacy in the head. Before they even prescribe a medicine, they even have an ingredient in a medicine that is non-existent in the ones in the pharmacy. They can even tell you there is a traditional medicine and herbal medicine I know that is not in the pharmacy, and this is the combination. Go take it, you will recover. And those are the people AI will not replace. So it depends on when you are in school, were you studying? What exactly is this in your head? You know, that use of the brain power, the human brain power, AI will not replace. If there is an area that we will take longer for AI to destabilize is healthcare, because of the sensitivity of that docket. But we will have crying doctors on the streets who will be the Google doctors. Thank you.
Elizabeth. That's Dr. Elizabeth. Okay. Thank you very much, Liz. I like that. Dr. Terry.
So going after that, what I'm going to say might sound controversial. Might sound controversial.
Yes. We are
But I
ready.
hope it lands. Like I hope what I'm trying to say actually makes sense. And maybe let me use an analogy to explain what I'm trying to say. When human beings invented, like artificial intelligence is another evolution, quote unquote, like the way we designed or came up with an engine, right? And before an engine, people used to move, right? From point A to point B. And people who did not have like means to move faster used carriages, right? And there were carriage drivers, right? Um, Once the engine was discovered or built or whatever, the need for a carriage driver kind of plummeted, right? Like there's a more efficient way of me moving from point A to point B. Simple. So the carriage driver who remained relevant is the carriage driver who learned how to drive a car or how to use an engine. Simple. So the carriage driver did not lose their job of transporting people from point A to point B. They acquired a new skill set of how to move people from point A to point B. So yes, their job was replaced, but they still remained relevant, right? Now comes autonomous driving. And now, as a society, then when people talked about self-driving cars, it sounded like a concept that breached ethical boundaries or moral boundaries. And it sounded like something that maybe we should always have a human in the loop, to always be the one behind the wheel, so that we trust we we have an accountable person to blame if something goes wrong, right? And now we have, once we get closer and closer to the subject, and autonomous cars are proving to also meet the safety criteria that a person who's driving, or even better, then we are more accepting now of self-driving cars, right? So I think the conversation around replacement and AI and whatever field that you think about it, healthcare, finance, agriculture, whatever, it's like the effect of the engine. It will affect every system. It will affect how people do their day-to-day lives. So maybe it will replace the need for an interpretation of a radiology image, right? Or and maybe we will have a human in the loop up until one point where we have AI systems that are more accurate, and you don't think to counter check your Google Maps and where it's directing you. It's like you start Google Maps, and if it tells you you turn right because it's probably more accurate than the soldier up the road who told you when to ukiangalia, right? I feel like that's the
Yeah.
mentality that maybe we should approach the replacement conversation, that maybe a replacement is also okay, right?
Yeah.
Maybe it's also okay.
I think you didn't even sound controversial at all from what Liz said. Yeah.
Then it has landed.
Yeah. It landed, and it landed perfectly well. I wonder if Faith, you have like half a second, like we are like extremely uh, out of time. Like Faith, do you
And
want to say
before it's
something?
quick, yeah, I wanted to add something on what my predecessor has said. So
Yes.
I think we should be looking at it from a point of redefining roles other than really eliminating them. For example, if you work at the triage in a hospital, you should because it's more like something to do with collection of data. So you should just redefine your role, upskill yourself, and look at how you can plug AI into that role. Because if you remain mundane, or rather, if you just remain that way, a pen and a paper, you're going to be replaced by someone else who knows how to use technology and AI-enabled tools to do
Yeah.
the same work that you're doing. Yeah, thank you.
I totally agree. I totally agree with you. Yeah. There are just certain tasks that will be, replaced in a hospital setting, and there are certain tasks that we cannot leave in the hands of the person we don't know. But anyway, yeah, point is home, and I think thank you very much. I wonder if like we have like two quick questions, and then we'll just and you are standing, your questions are in the middle of us and the refreshments out here. So yeah, let's. Here's the mic.
Okay, interesting conversation from the panelists. Thank you for making time, and also the organizers from organizing this wonderful event. So my question is, so does this mean, no, we are talking about the role of AI and data science in precision health and all that. So does this mean we have to encourage more of doubling down the data science, I know, the convolutional neural networks, I know, to back to basics. No, let's go back, collect data first, and maybe build solutions that are more adaptable, more, can I say, user-centric? Because honestly, talking about now I have all this knowledge about data science. My solution is I'll think of a problem. Now this is a valid problem. Now come up with a model, come up with say whatever, like something a llama built or on ARM architecture. But that will not solve a problem kwa mtu mwenye ako kwa ground. So does this mean as much as we're learning AI, learning data science, we should think about doubling down and thinking of solutions in the most basic form? Yeah.
Solutions that don't. There is a point you talked about.
That's a very good question. That's a very good question. And I don't want to say that I have the full answer, but this is my perspective. There is the role of the technology builder, right? And that is your role, to understand how to build the tech. Then there is the role of the people who understand the problem and the people who understand, who know the problem, who've worked with the problem. And I think the ideal solution would be a collaboration between these two people, so that it's not only on your shoulders as the technology builder to also go back and understand healthcare, because surely that's too much of a task, right? I think that's too much of an ask for anyone to go back and understand healthcare fully, and then now see like, okay, yeah, for this problem, this technology solution works or should work, right? There's the people who understand the problem, there's people who build the solution, and they should work together. And it's conversations like this that then allow the medics to come on board and be like, oh, okay, yeah. Maybe in my clinic, I have a problem like this. What do you think is a solution? So that maybe the solution then is a very complex system, right? But then it actually fits within the gap. Yeah.
Let's go for your question.
Okay, hi again. To actually piggyback on what she's saying, my question kind of goes along that route. We've had a very fruitful conversation regarding practicability and reliability centered on the user, but also as well us as the developers having this simplifying, looking at the bigger picture to simplify what we need to do. So my question is, with the unique uh, perspectives you all have, yeah? As Dr. Elizabeth, when she comes with the knowledge from developing the AI systems, Dr. Terry coming with the intersection knowledge, and also Dr. Wambui, how, what health gaps have you identified thus far, with whatever unique experience you have, that data can help minimize and eradicate? For example, one of the solutions you gave, Dr. Elizabeth, was maybe um, incorporating the community into data collection. And yes, I do understand that the health uh, sector has sensitive data, but I don't want us to forget that the only data that we've been talking of so far is the user data, but every other step has data, even when Dr. Wambui mentioned at the start when it comes to policy. So there's a lot of moving parts. And as also Dr. Terry said, health is plagued by a lot of holes. So which spaces can we identify to help and educate? And that's why I'm saying everyone has a very unique perspective.
Yeah.
Her as a client and as a developer, she sees something the medical experts don't see.
Yeah.
So what can she tell them or us? And now the people in the medical field, what can they tell us to look at so that our data and our decision, because it's what drives the decision making, help to, also curb these challenges and talk about lack of data for us as Africans and building for Africans and building for women in Africa by women in Africa.
Yeah, I think let's have Dr. Wambui and Elizabeth. Then we just conclude the discussion. That's a brilliant question. Thank you very much. That was super, yeah, great question. Thank you very much.
All right. So for me, based on the statistics and based on the challenges that we are seeing, I'd say non-communicable diseases. Why is because the risk factors, the statistics, the incidence keeps going up. I think we are sort of now we've been westernized. I usually say westernization brings in the good and the bad. So now we've also become westernized in terms of our disease patterns. It's a very big issue, and especially around early detection, screening and early detection. So a solution that is very scalable, because there are solutions currently, yeah, but the scalability is the problem. So a solution whereby even the farmer down at, let's say, Bomet or wherever, who is developing hypertension, who is developing diabetes, is able to actually have an idea that this is something that should trigger me to go to the hospital. As for me, I see, of course, the emerging issues for me would be non-communicable diseases and mental health. There are other major issues, as Terry rightly said, health has so many challenges, but as we said, you have to identify one problem and you plug the solution to that problem and also look at the impact when you're looking at it. I'll give my parting shot as we finish off. I'm very passionate about digitization of health records. Why is because if we don't have health records in digital format, all this conversation that we are having here will not make sense. What I realize about patients is patients sometimes don't even know. There's someone who will have gone for a whole surgery and you ask them, you have a scar here, what surgery did you go for? They don't know. You see, now that is where we get challenges. That this is probably a mother who, in their first pregnancy, was diagnosed with preeclampsia, and they're coming for their third pregnancy or such. So you see, if we had very good health records, if we have the mother is working with, like, when we key in their name, we can see from wherever. It doesn't have to be like within the county, like nationwide. When we key in their details, we can see the whole medical history. Then you're going to be able to arrest some of these problems that you're talking about. Because yes, we have the solutions, but the detection, and that is where data really plugs in quite a bit.
Thank you very, oh my gosh, your insights are always on top. Yeah.
So let me just add something small.
Half a second.
Looking at the time.
Yeah.
Yeah. I know we've talked about data, scarcity of data. We need to collect data within the African continent. But I also would like to say this. There is a lot of data in the African continent. A lot already collected. But that data is privately owned. It's not available outside there for research purposes. If you walk through the hospitals, they have huge data sets, but they are not releasing it out. So the gap there, or what we can recommend is there is work or there is need for these institutions looking at how can they make this data anonymous, or what can be done to this data and then published outside there to support research purposes. And number two, which is the last one, within Africa again, we have so many PhDs. We have got so many master's graduates. We have got so many innovators and so many AI labs and so many AI apps that have done very nice developments, but no one knows about them. You graduate with your master's, you've done a project in AI, you put it on the book. That book is called thesis, is a thesis. and you forget about it and you celebrate, and now you call yourself a PhD holder. And that is it. And the doctor comes in, but adds no value until you push yourself post the PhD and go outside there, tell people this is the research I did, and these are the next steps, and this is what I'm working to push this development to the marketplace. Yeah. So that's another huge gap, that we've got so many scholars, but what they developed is of no use to anyone, but they have the master's degree paper on the streets and the PhD on the streets. So let us put some energy, especially the PhD students who are teaching in universities and not doing anything past teaching, and do something important. Go outside there, speak, publish, go to the lab, a lab like this, identify the tech industries, collaborate, and try to see how you can scale that product to the marketplace. Thank you.
I think that's a good one for us guys, right? Faith, do you have like your half a second say? And maybe Dr. Zin is like one last thing. Faith,
So, yes,
do
for
you
me,
have
okay. So I would say that when it comes to AI and healthcare, it's really a growing industry, or rather space that we really have to occupy and take our space there, do research as Daktari has said, and as innovators, make sure that you really push your ideas through. There's a lot of funding around AI and stuff. Make sure that your voice is really heard. Even as females, make sure that you really own your space, represent yourself, and speak up. What's the worst they can say? Just a no. But make sure that it's not a phase that's going to pass by without you really having left your footprint in the sand of times. Yeah, so that's all I'm going to say. Thank you.
So just to come back to the question you asked, and I think the conversation today has solely leaned on artificial intelligence for clients or patients. Like, do not forget that artificial intelligence can also be for physicians. So there's the clinical decision support, there's maybe note taking, there's appointment scheduling, appointment reminders. Like, don't forget about artificial intelligence for that space as well. So there's gaps even as a clinic, as I said, in answer from people who seek healthcare. The problems start from the people who seek healthcare all the way to the people who practice healthcare. So patients, doctors, policymakers, even leaders, as they're making decisions that affect healthcare, maybe artificial intelligence could help them in that space as well. So maybe think about it like that. Parting shot for me is as Faith has rightfully said, artificial intelligence for healthcare is at its young stage, and I feel like if anything, that should be more. That's a very exciting space to be in when something is at the budding stage, because you get to see a good chunk of its development story compared to when something already exists and innovation around it is very minimal. That leaves room for growth, maybe even in areas that we are not thinking about today. So don't even limit yourself to what we know healthcare as today, right? Maybe there exists a version of healthcare where you don't actually have to go to the clinic at all. And that's a version of healthcare. So I think for me, it's the exciting possibilities that it brings should be enough to keep you in it. Yeah.
powerful ending? Thank you very much to our panelists, guys. Can we appreciate Dr. Wambui, Dr. Terry, and Dr. Elizabeth? And Faith, we truly appreciate your time and, thank you for sharing all your insights. So at this point, we'll just quickly close the session because there is nothing more to say, guys. We've digested this topic. In case you have any questions, like we will be networking around, and so this will be a wonderful moment to do this, right? So guys, we have are you on the chat? Please post the link for people to rate us. to evaluate us the the feedback form. So we have a feedback form, guys. Would love to even do to even do more of this mentorship, like, I mean, please just give us feedback of what exactly you want to hear next, or if the sessions today really satisfied you, and like, was it valuable, etc., and so forth and so on. So we have a feedback form. It's very important for us to improve the work that we are doing in terms of promoting data science here in Kenya. So we'd really love it if you can take a moment to just share feedback with us. So guys online, if you can just, have you shared it? Kindly okay, so okay, let me just check if this is, but what about the people who are here? How are we going to share this feedback form? Can you post it on WhatsApp? Yeah, also post it on WhatsApp. So the link is there. The people are joining us online. So the link is there. Please give us your feedback from the opening remarks to our keynote to the session led by Lillian and the panel. Just let us know if you were satisfied with everything. Yeah. If you are not on our WhatsApp, how do they join the WhatsApp again? Do you know? And you can also, for the ones online, you can share the WhatsApp link. Yeah, I don't have it. Okay, we'll figure it out. The people who are here, like all of you, you guys must fill out the feedback form. It's very important. The people online, I hope you can see. I just posted the link, and yeah, please give us your feedback. Okay, away from the feedback, I would like to thank each one of you for joining us today. It was a successful event, not because of from the organizing, but also because like you are here. Like it couldn't have been a success if you didn't make it here, and you had to postpone several other things just to make it. And we truly appreciate your time. That's why we need to know if your time was really spent well, right? So otherwise, this is like WIDS conference, and we do host monthly WIDS data drill sessions. So this is like WIDS conference. We hosted WIDS datathon workshops, right? We don't stop at the conference because this is something we learned from, again, feedback. We got feedback from our previous attendees, and they were like, you can't stop at hosting datathon workshops and conferences. Please host, let us engage more beyond those two events. So we do host monthly data drills, and we will communicate when that start. I think Brian is gone already. So yeah, and to our guest speakers, we truly thank you. Like preparing the presentations is not so easy. I'd like to thank Kathy Muraga, who is our MD here at Microsoft. She started us off with a powerful opening remarks. It was great. I hope you guys felt motivated as I did. And then Lillian from her talk, and Dr. Terry, we truly appreciate your talk as well, and also the keynote. And Faith, thank you very much for providing us with the solution for the Datathon challenge. At this point, we'll close the session, but this time around, I think for the first time, we'll have extended refreshments beyond juice. We will have tea, and we'll have snacks. And I can't wait for us to connect. This is also the most important part. I'm so sorry we just things we are ending this late, but let us have our coffee and network. The networking is so important. Remember what Kathy said. It's so many of us we get jobs through these sessions, and Terry just mentioned that she's a living testimony. She got her job from networking here in WIDS. So guys, thank you very much, and yeah, thank you for making it.
Guys, if you are not in the WhatsApp group, you can see me right now.
Yes, yes. See Jen to join the WhatsApp group. Have you posted the link for the feedback on the WhatsApp?
They join first.
They join first. Okay. So do that and then we can you can rate us. Thank you guys for joining. I'll just end this call. Oh my gosh. And it didn't happen if we didn't take a picture. Can we take a picture? Like a group picture, but is it cold outside? Thank you, everybody. Faith, bye. How do we see you online? Okay. You are asking questions. Kindly send the WhatsApp link here. How do I send the WhatsApp link there? Just try my best. Out. I was almost ending the call, but here, let me just address the question. I'll just stop recording first. Can we take a picture, guys? Like quick picture out here. Then I need to share it on the chat so that people can join me. Somebody is asking us in the chat.
Yeah. Okay.
So, guys, we are taking a picture. Please don't go without taking a picture.
Oh,
Don't stand in between the door.